I don't know if you can you hear me, Linda? Perfect, okay.
Good morning, everybody, and welcome to the 2020 Periodic Paralysis Association Conference. We wish we could be with you in person today, as we have for many years, but due to the COVID virus, we had to take this conference to a new virtual level. The good news is that we have a larger attendance than ever before, with more than almost 700 people watching from around the entire globe today. We thank you with extreme gratitude our premier sponsor of today's webinar, Strongbridge Biopharma. Their ongoing support is unparalleled, as is their friendship. We hope to be back with you in 2021 at a live in-person conference. And we will just have to wait and see where this new normal will take us in the coming months. We have a wonderful program for you today, and we are on a tight schedule to bring you as many presenters as possible. We have a couple of 5-minute breaks built in. One will be at about 12:55 p.m. and another at about 1:45 p.m. You will see screen messages on your monitor during these times, and we hope that you know you can get up at any time during the day and move around or get something to eat because you're in your own home. This conference is also being recorded and will be placed on the PPA website as soon as we can in the coming weeks. It's now my great pleasure to introduce you to our wonderful board of directors. I'm hoping the slide will change here, maybe. Just a second. There we go. My name is Linda Feld, and I think most of you know me because you've talked to me so much, but I've been with the PPA since about 2000. I am now president of the PPA. Part of what makes my life so easy and enjoyable is the fact that our board of directors are a close-knit group of individuals who are moving the PPA into the future with exciting ideas and never-ending support. First, I would like to introduce Jeff Albertson, our secretary, who is a longtime personal friend of mine who keeps records of our meetings and reviews content we write for accuracy. I have never known anyone who can always find the exact right words for any situation as well as Jeff can. Next, we have Eric Sanders, who is our IT director, without whom we would not have a website to function from. Eric and our server for the PPA website live in the Netherlands. Monica Kramer is our treasurer, and she has streamlined our financial records, donations, and operating expenses for us. She and her service dog, Fozzie, always keep us laughing. Our newest member is Evelyn Black, who oversees growth and development. Evelyn had COVID this year, but has recovered, and you will be seeing some exciting new initiatives for the PPA in the coming year, which she will be designing. The entire board now lives near one another here in Central Florida, except for Eric, who we see on Skype, so we can interact and brainstorm in person. Thank you to all the board for making this webinar possible today. One last note, on your screen you have a sidebar, and you're going to see a place where you can ask questions. Please feel free to add questions throughout the day. If you want an answer from a particular doctor, please specify their name. We will answer all questions either live today or by return email. I would now like to introduce our first speaker, Dr. Nivedita Jerath. Dr. Jerath is a board-certified neurologist with outstanding credentials and a special interest in helping patients with hereditary motor and sensory neuropathies. She's a proud graduate of Harvard University, where she was an award-winning student and athlete. She earned her medical degree at the Mayo Clinic College of Medicine and returned to Harvard for her neurology residency. She next followed her husband to Iowa City, where she completed consecutive fellowships in neurophysiology and neuromuscular diseases, and earned a master's degree in translational biomedicine at the University of Iowa. Before moving to Central Florida to serve as a neuromuscular division director, Dr. Jerath served as director of the Charcot Marie Tooth Association Center of Excellence, and as a clinical assistant professor at the University of Florida. She has become a beloved favorite of our periodic paralysis patients struggling to find a diagnosis, and has been a pioneer in this field, with us using telemedicine to see patients far and wide. We're looking forward to new things in the future with Dr. Jerath, and so I'm going to turn it over to her now. Just a minute.
Thanks, Linda. I'm trying to get my screen. So okay, share.
Okay.
And hello.
There
Hi,
she is.
okay, so I want to share my slides. How do I go ahead and do that? Show my screen. Perfect. All right. So here we go. We've got a lot to talk about. And let me go ahead and start. Thank you for the warm introduction. All right, so let's get started. We have a lot to talk about in the next hour. So welcome to the Periodic Paralysis Association Conference. What an honor to be here. Thank you to Linda. Thank you to the PPA. I am blessed to be the medical director of neuromuscular medicine at Advent Health Orlando. That was formerly known as Florida Hospital, and it's a big hospital system in Florida, and it's been rebranded as Advent Health Orlando. And it's a great place to work with tremendous support for patients as well as research. So really blessed to be part of the program. So today we're going to start a journey. And as Linda alluded to, was that we are going to revolutionize and try to change the field of periodic paralysis and move it forward. Now, the journey began, of course, when I was in medical school and when I was in residency, but it also started last year in Orlando when I was just joined the Periodic Paralysis Association conference and sat in the audience. And in 1 year, I'm presenting, and I'm so blessed and so honored to be here today. I just can't thank you enough. The main topic of our discussion is that periodic paralysis is challenging, not just for patients and caretakers, but also for providers. And I want us all to enter this journey. And I want us all to discuss those variables of why it is challenging and how we can make things easier for everybody. So let's start this journey. So today's agenda is that we're going to discuss what is known, what is in textbooks. We're also going to discuss what is unknown, what is more challenging for patients, and is also very, very challenging for physicians. We're going to discuss treatment options as well as difficulties for patient care, and then we're going to conclude. I do want to direct everyone's attention to this photo. Now, this picture is a wave. This was a valuable picture of one of my mentors at the University of Iowa. I had a phenomenal experience there in Iowa. I learned so much from the giants in their field, including Dr. Michael Shai. I honestly tell you, I wouldn't be here without him. But here is Dr. Yamada. He kept this picture in his office. And you can see this wave. This represents like the old school thinking. And this is a digital transformation of this wave. And I feel that in periodic paralysis, we're going to have a transformation, not just in the periodic paralysis, but in a lot of the hereditary neuromuscular conditions. This picture, Dr. Yamada was one of the leading experts in epilepsy and EEG. He showed how much EEGs transformed over time. And I feel that in our current situation, neuromuscular medicine is going to be transforming, and we're going to go through some of those changes. So, but before we go through that, I want to tell everybody what is known. This first half is going to be more of a textbook lecture to actually understand what doctors are thinking when you walk into their office or into the ER, to see what has been written about periodic paralysis? What do we know in our textbooks? So all of the periodic paralyses, these are categorized as channelopathies. They are muscle channelopathies, and they involve ion channels. Just imagine for a second how hard that is to really understand. It may be easy to understand our eyes and our nose and our mouth because we see them, but we don't see ion channels very easily. So that makes the diagnosis, the presentation more challenging for everybody. Ion channels, you can see this picture here, they serve as the function of excitability of nerve and muscle memory. So they allow for different ions to go in and out of potassium, sodium, and calcium. And all the channelopathies are disorders that result from abnormal ion channel function. This abnormal flow, if you have that, can cause weakness or paralysis because the channels control whether a muscle contracts or relaxes. Here's a list of a lot of the ion channels. Here we have myotonia congenita, hyperkalemic periodic paralysis, paramyotonia congenita, the potassium aggravated myotonias, hypokalemic periodic paralysis, hypo and hyperkalemic periodic paralysis, and Anderson-Twill syndrome. You can see a lot of them have affected channels, chloride and sodium, calcium, so a lot of them repeat themselves. Here is another slide to just outline what exactly we're going to discuss in the next few minutes. So we were going to talk about the hypokalemic periodic paralysis. There's a type 1 and a type 2. The hyperkalemic periodic paralysis, paramyotonia congenita, myotonia congenita, and Anderson-Twill syndrome. In general, a lot of these channelopathies have an autosomal dominant inheritance. For those people that don't understand that, that means that their condition is seen in every generation if it's passed on. So for example, if mom has it, then mom has a child, the child has a 50% chance of getting it. So, and then that child's child has a 50% chance of getting it. So if it gets passed on in each generation, it's possible. That's how autosomal dominant syndromes work. The onset for all of these are typically written in the textbooks first or second decade. Patients can get episodic attacks of flaccid weakness and feel very floppy and weak, which per textbook are often triggered by diet or rest after exercise. So a little more of our textbook definition. It's really helpful to understand what doctors have read about so that you can understand what they're thinking. So the hypokalemic periodic paralysis, those are disorders of the CA-CNA1X and SCN4A genes. The paralysis have early to late onset. The duration can last up to 20 hours. Not only can they have paralysis episodes that come and go, but then they can get fixed proximal weakness. So they can get weakness in their shoulders or their legs. They can, in the paralysis episodes, can be fully paralyzed or mildly paralyzed. Sometimes the heart or the cardiac arrhythmia can occur, or the lungs, people can have difficulty with breathing. Some patients will say, well, right before their attack, they'll feel numbness and tingling and fatigue and difficulty with thinking and behavioral changes just right before it occurs. They say sometimes that the myotonia doesn't occur. The attacks are usually triggered by physical activity, a high carbohydrate diet, sodium intake, alcohol consumption, emotional stress, viral illness, and sometimes menstruation. Meds such as steroids or insulin can trigger the attacks. And acetazolamide, they've said in these textbooks, are helpful in some of the mutations like the CA-CNA1S mutation more than the SCN4A. And you'll see some of these descriptions will be repeated in our next few slides. I did want to discuss that there is a diagnostic criteria for the hypokalemic periodic paralysis. This is definitely old, but I want all of you who are listening in today who have this diagnosis to actually compare your notes. Do you fit this diagnostic criteria or you don't? Are there symptoms that you have that are different? And definitely send me a message or discuss this, because it's important for this field to move forward, for us to figure out, is this criteria, does it include everyone? So the diagnostic criteria says here 2 or more attacks of muscle weakness with documented potassium less than 3.5, 1 attack of muscle weakness in the patient, and 1 attack of weakness in one relative who also has to have a potassium less than 3.5 and at least 1 attack. 3 of the 6 clinical or laboratory features should also be present: onset in the first or second decade of life, a duration of attack greater than 2 hours, positive triggers, improvement with potassium, positive family history of a calcium or sodium channel mutation. And I can tell you, some of you are saying, wow, you may not have all of these. So that's why I brought this slide to the table. We have another condition, hyperkalemic periodic paralysis, but also the SCN4A gene. And attacks can occur in the first decade of life per our textbook. They can have myotonia, which is muscle contraction, no myotonia, or paramyotonia. Their symptoms can be worse with cooling. And triggers could be just the morning, rest after exercise, potassium-rich food, and then also stress. Paresthesias can also occur. So some people can have problems with numbness or tingling. And that's important prior to the episode. People can have achiness, they can have thigh and calf muscles involved. Episodes can last about 2 hours typically. And then sometimes when we tap on the reflexes, those can be diminished. Some people will have pain, and some people will have what we call proximal weakness over time. So they will have that weakness, which we discussed also in the hypokalemic periodic paralysis. Let's move on to these textbook, from these textbook definitions to another diagnostic hypokalemic periodic paralysis similar to the hypo. 2 or more attacks with a potassium greater than 4.5, an attack in a family member with a serum potassium greater than 4.5, as well as 1 attack of muscle weakness in the patient. So you could either have the patient having the documented attacks with potassium greater than 4.5, or a relative who's had it, as well as some of the 3 of the 6 clinical or lab features, such as onset before 3rd decade, duration of the attack less than 2 hours, positive triggers such as exercise and stress, myotonia, positive family history, or genetically confirmed sodium channel mutation. Paramyotonia congenita, this is another channelopathy with a mutation again on the sodium channel gene, that's SCN4A gene. Patients can have this with hypokalemic periodic paralysis. That makes sense because the gene is similar. Para just means it's paradoxical. So if they exercise, they get worse. They also get worse with cold. You can see the picture here, so that's not a great place for them to be, although it looks lovely. They can have focal or generalized attacks of weakness. So again, when they have weakness, it can be either focal, generalized. This is repeating what the other disorders had. They can also have the fixed progressive weakness, as well as paramyotonia seen in infants. And then speaking of that, you can see a young child here with myotonia. He has difficulty with opening his eyes. Myotonia congenita also is SCN4A gene, as well as the CLCN1 gene. Patients will have difficulty opening their eyes. They have stiffness in their legs when walking. So they have just so much more muscle contraction, a lot of muscle pain, and they have difficulty with chewing and swallowing. Their symptoms also get worse with cold. They have mild weakness proximally, but that varies. Sometimes if they have the SCN4A gene, they have a more painful variant. Here is an example of muscle hypertrophy. Hypertrophy, you can see how well defined the musculature is in this patient who is 22 years old and had a mutation in the SCN4A gene. He has very well developed muscles because he has myotonia, and the muscles are constantly contracting. And sometimes this is a helpful diagnostic clue for the diagnosis of myotonia. They describe him as very Herculean with a very well-developed musculature at a young age. Here is one of the last textbook syndromes I'm going to be talking about is called Anderson-Twill syndrome. That's a mutation on the KCGN2 gene. And this involves periodic paralysis that is triggered by rest following exertion. I had a patient who would exercise and go outside and enjoy the day, and then he would enjoy his favorite recliner right after. And as soon as he rested in that recliner, he was completely paralyzed and out for hours, and nobody could figure this out. So it's rare, it's hard, it's a difficult diagnosis to make. Patients will also have cardiac issues such as ventricular arrhythmia associated with long QT syndrome. Patients will have skeletal developmental anomalies. You can see here a picture of that with a broad nose and a broad forehead, and sometimes they have a short stature. All right, so this is our slide to signal that we are moving on from the textbook to more of what Dr. Jerath or what I'm going to talk about. And my view of periodic paralysis, we're going to go from textbook to what we see in the future of periodic paralysis, I'll tell you more, maybe more current view, and I am blessed to have quite a few patients from across the country to get a different viewpoint of the periodic paralysis, and so we'll be transitioning to that right now. So this is my view. I have a picture here of how I see things in a different way than perhaps other physicians do. I believe that periodic paralysis is a spectrum. As I've already alluded to many times, these disorders, these channelopathies, have multiple genes that they share. So when I have a patient that comes in, I don't try to put them in a box. A lot of them will share similar symptoms of myotonia. A lot of them will share similar issues of paralysis or the need for potassium to make them feel better. Some will not respond to potassium, but that sort of spectrum is important to move this field forward. If we start, sometimes I feel if we put it in a box, not everyone will fit into a category. So it's hard to place every patient in a certain box. And not only is it hard because the diagnoses are hard and the channelopathies are hard, but every individual is different. I'm sure a lot of patients are shaking their head, oh yes, they are, and my patients are so different. But they share a common symptom of the paralyses. They all get paralyzed, that's episodic, but they have different presentations sometimes. I did want to throw in that the paralysis is pretty rare. A hypokalemic, it's 1 out of 100,000, is more common. Hyperkalemic is 1 out of 200,000, and Anderson-Twill is much more rare, 1 out of 1 million. We are still learning. So this is the really crucial slide of my talk, because we don't know everything about periodic paralysis yet. Just imagine those patients that had symptoms about 20 years ago. I have heard stories from my patients that their grandfather or grandmother were thrown into insane asylums because they would get all upset and then they would get paralyzed. And so physicians had no idea what was going on. And so periodic paralysis at least has improved and moved forward over the years, but we still have a long way to go where we don't really know much about these conditions. It's rare and they're hard to diagnose. So one of the things I'm going to start off that we are still learning is that patients don't always need to have potassium being high or low. And you can see that diagnostic criteria, that how physicians think that the potassium always has to be high or low for the diagnosis. And I am on the phone all the time with an ER doctor trying to explain this concept. So there is the condition, of course, normokalemic periodic paralysis. So that does cause similar symptoms. We have a lot of knowledge gap in the mutations. And I know Dr. Cannon, who will be speaking later, is an expert in this. But just for instance, the RYR1 mutation is new. And it produces overlap syndromes. It produces new symptoms that we're learning about. So that in and of itself, it makes the diagnosis challenging. There are many more genes that we don't know about. One of the other things we're still learning is attacks can be long. We say 20 hours. If you read the textbook, I have patients that have had attacks for much longer than that. Myotonia and paralysis can potentially alternate in episodes that look like seizures. And that, to me, are very passionate in bringing to the table and bringing physicians to learn more about that condition. I had a few patients who was very intrigued by this, that when they come to my clinic, they'll have this myotonia, where they'll have muscle contractions, and then just flaccid paralysis right after. And when we think of periodic paralysis, we just think of just paralysis, right, in the textbooks. But sometimes myotonia or muscle contractions can alternate with that, with the paralysis episodes. And so a lot of physicians, a lot of ER doctors will say, okay, well, is this a seizure? Because that looks like a seizure, but the patient's talking through it. Okay, then they go into saying, well, this is conversion, or this is psychiatric. And so it's a confusion. I think these type of episodes really need to be, we need to learn more about it, and physicians need to learn more about it. We need to understand them a lot better. But you can just imagine if it's a channelopathy, that sometimes the muscles are contracting too much, and then sometimes they let go in paralysis. So that's my hypothesis on that. There are a lot of patients with unknown treatments. This is really hard because patients were so excited to get a diagnosis, and all of a sudden they're sensitive. We don't even know how much potassium what the long-term side effects are of potassium. And so we have that as an unknown. And some people are just so sensitive to medications that we offer. And that makes things quite challenging as well. We did discuss pain in the textbook, but what I'm discussing is not just the simple pain. I am talking about excruciating pain. This is pain that my patients say, Dr. Jerath, I don't want to live anymore kind of pain. Pain that makes them run to the ER every 2 weeks or even sooner. And doctors, again, don't understand that. That is a really important part of how we want to revolutionize the field, because we want to make sure that people understand this is not an easy diagnosis. If someone's hand gets cut off, yes, that could be painful, we see it, but people don't see the excruciating pain in a channelopathy. But can you imagine if the muscles are contracting all day? That is painful. Some have migraines before their episodes, again, that can distract physicians who think this is a migraine. Some people can have spasms in their throat or diaphragm muscle, so again, that's a diagnostic challenge because people don't understand that. And some can have a later onset than what's true. This is an important paper for me. Some of you may recognize this paper. This was written by our cherished scientist and physician, Dr. Lehman Horn, in 2013 about a family who had a transient compartment-like syndrome and normal kalemic periodic paralysis due to a calcium channel mutation. So again, this is a periodic paralysis with normal potassium. The family was known to have cramping and weakness. They also had muscle weakness, a progressive myopathy, and triggers were cold cold as well as rest after exercise. So I wanted to just have a thought experiment for just a second about this paper. Just imagine what this family had to go through when before this paper was published. Just imagine the uphill battle to get treatment, to get an understanding of the disease. So if we think for a few seconds of how this poor family had to struggle to get a diagnosis, and they finally found someone who helped them. Just imagine what you're going through right now. If you are having trouble with a diagnosis, if you don't have a mutation yet, it's okay, because we still don't know a lot. Just in 2013, we're publishing about periodic paralysis. It's 2020. We have a lot to learn. We have a lot of genes to discover, and a lot to understand about this condition. So I feel bad that this family had to go through so much, but at the same time, we found an answer. So that's what our goal is today, is to move the field forward and to learn more about these periodic paralyses. So another thing that we're learning are the new genes. I was fascinated with the RYR1 gene. It can cause many different conditions, including hereditary muscle disease. But there was a paper in 2018 that illustrates how it can cause a late onset atypical periodic paralysis with and without associated muscle myopathy or muscle weakness. So some can have muscle weakness and some can't. There is no consistent relationship to food or temperature across all these cases, and many of them have muscle pain or cramps that are predominant. One of the things I do want to say is that just in the last few weeks, I've had a few patients with this, and they have different presentations. So it's really important that we collect this data and learn more about these mutations. This is a slide of those cases in this paper written in 2018 in the Neurology Journal. I really do want everyone to see this from a bigger picture point of view. Look at this case 1. The onset was at age 34 years, so it was a later onset. Case 2 was also 23 years. That's when the episodic weakness occurred. And case 3 was 14 years. So most of them were a little bit later onset than usual. But what is really interesting about this chart is none of these things are the same. So the examinations are different. The CK is a little different variable. And EMGs, of course, we see 2 normal, right? And then 2 with myopathic changes or muscle disease changes. The McManus test, which is another indicator for periodic paralysis, is positive in only 3, not the 4th one. So these symptoms and the workup are not all the same. Can you imagine how hard it is to diagnose these kind of patients? Even a muscle biopsy is not all the same in the patients, but everyone does have a variant in RYR1, and everyone does have episodic weakness. And that's why I feel like we should push towards improving our diagnostic criteria so patients can get the treatment they need and we can understand this disease a little bit better. Here, I had one of my favorite patients. She had an SCN4A mutation. She had prolonged attacks in hyperkalemic periodic paralysis. Can you imagine? She's a young woman. Her episodes last from weeks to months. She's had a million episodes of muscle cramping. Her scalp, her vaginal area, every muscle cramp all day. And that just brings tears to my eyes. I don't know how she manages that and how she tolerates that. But she has breathing difficulties. As of the last year and a half, she has had muscle weakness and burning. And she has burning in her deltoid and quads. And when she brushes her teeth and puts on mascara, she used to take a lot of breaks. It needs a lot of time. It's very painful. We did try to treat her with baclofen with a little bit of improvement, but it's still been difficult with allergies and so many other issues that we have to deal with. I do want to talk about some unique characteristics of pathogenic mutations. All these patients had paralysis episodes. So we did have a pathogenic mutation in these genes. All of them had paralysis episodes, but they all had interesting features to their presentation. For the CLCN1 gene, this patient had hand cramps. Can you imagine the physician who sees the hand cramps? Probably the first thing they think of is, this could be carpal tunnel or something else. So that's not an easy presentation or something that we can figure out right off the bat. The next gene mutation we have here is that the patient had digestive pain, bladder emptying difficulties, paralysis episodes that last 5 to 6 months, cramping and leg swelling. That in and of itself is a diagnostic challenge. And so patients like that have a very difficult time finding out what's wrong with them. We have another patient here who had normal kalemic periodic paralysis, and the potassium was normal. This patient had burning pain in their arms and paralysis after headaches. Nobody could understand what was going on. The headaches threw physicians off, the burning pain, nobody understood. The SCN4A mutations, patients have chest pain, throat pain and pain. There's a patient who had that worse pain worse than menstrual cycle, and that was unusual. She also had difficulty with diagnosis as well as treatment. So here is another mutation found in 2013. It's a novel ATP1A2 mutation in a patient with hypokalemic periodic paralysis, but also had central nervous system symptoms. So this was a child who had hypokalemic periodic paralysis, but also developed seizures as well. And then they discussed that this gene could be linked to the hemiplegic monitoring. Now, I do get questions in my clinic all the time. I am so honored to be able to try to answer them. One of my patients asked me, Dr. Jerath, could this be myasthenia? And you know, my answer was, it depends. I'm not sure. We have to investigate. So here is a patient who in myasthenia classically has eye droopiness or difficulty with eye opening. That's called ptosis. And here's a video of a patient who had the myotonic lid lag sign. She was trying to look down and it took a while for her eyes to close. And then she also had difficulty when she closed her eyes to open up her eyes. And you see here that she had what could look like a droopy eyelids and ptosis. For those patients who feel that they have these symptoms, that is myasthenia. I see this in my clinic quite a bit, but I just wanted to illustrate that. But then that's why I say it depends, because there are cases where there is myasthenia gravis. There was a young woman who was written about in 2019. She had severe muscle weakness, difficulty with breathing, and hypokalemia. She was intubated. So as soon as she came to the ER, she had to get a tube down because she couldn't breathe. And the doctor saw that her potassium was low, so they normalized it. And she improved. Her arms started working, her legs started working, but she continued to have difficulty with breathing. So what the doctors remarkably did was they actually checked for another disorder. And they checked the acetylcholine receptor antibody, and that was positive. So there was a diagnosis for her, as she had myasthenia gravis and hypokalemic periodic paralysis. She improved. She got the tube out after they treated her for the myasthenia. So they gave her mestinon and steroids and plasmapheresis. And so it's important for those patients who have difficulty with improving their weakness. It's always important to look for a second disorder to make sure that, even if potassium is improved and if they're still weak, it's important to look for something else. So when patients ask me, is this myasthenia gravis, Dr. Jerath? It depends. We have to evaluate. We have to know everybody's story. So I have had these questions as well: pregnancy and periodic paralysis. And this is where we really are lacking in terms of knowledge. There are mixed results, but they're just individual case reports. So when I was searching this, there were cases that said that pregnancy can worsen hyperkalemic periodic paralysis. There was a case report where menstruation pregnancy can worsen the hypokalemic periodic paralysis. And then you have a whole case report here where a patient with hyperkalemic periodic paralysis got better during pregnancy. She would have one attack a week when she wasn't pregnant, and then when she was, she had only a few mild attacks and 4 severe attacks that occurred. And then as soon as she delivered the baby, she started going back to her frequent attacks every week. So this is a very hard topic. It's variable. We don't really know very much about it. Some of my patients ask me, why, Dr. Jerath, am I so sensitive to colds? I can tell you right after that, Dr. Cannon knows this so much better than I do in terms of the physiology about it, and I know he wrote a paper on this. But the easy answer is that the extreme cold can just affect how that ion channel functions. And if you want a more academic answer, sometimes that cold temperature can just destabilize the slow inactivation as well as the fast inactivation, and that just can cause the membrane to be depolarized, and it's really hard for that membrane to be excitable and for muscle activity to occur. So that's a more academic answer. There are probably a lot more details to that, but just essentially the extreme colds can affect how that ion channel functions. The reason why I bring this video into the picture is because I want to say that we are still learning, and I want to really encourage all the physicians, all the caretakers, all the family members, all the patients to really, and of course the patients have the most open mind, but everyone else who really has to support our patients, it really should just have an open mind. And we can learn a little bit about this horse who has hyperkalemic periodic paralysis. And you can see here the muscle contractions. And we'll let this video run for just a couple of minutes. And you can see that here.
It is believed to be a natural mutation that occurred as a result of evolution. However, it became widespread as a result of breeders' desires to produce horses with heavy muscles. And as we all know, the American quarter horse is very famous for its athleticism and well-muscled beauty. Impressive was an exceptional horse and the first horse in his breed to become an AQHA world champion, open age halter stallion. It is his muscular and refined form that led him to sire 2,250 foals and about 55,000 living descendants as of 2003. I find it very interesting that Impressive never showed any symptoms of the HYP disease. However, all horses, and repeat, all horses with the disease have been traced back to this stallion, Impressive. What makes it even more interesting is the fact that HYP is an autosomal dominant mutation. It requires only one parent to have the gene and pass it on to the offspring, and it does not skip generations. One homozygous parent will result in all offspring carrying the defective gene. So while it may seem that some horses exhibit little to no signs of the disease, it is not possible for it to get diluted, in quote, contrary to what some people might believe. However, some affected horses show little to no signs or symptoms through their lifetime, while some others experience it frequently. HYPB is known to be triggered by high potassium levels in the blood, also known as hypokalemia, stress, general anesthesia, lack of exercise, or concurrent illness. Research has also shown that younger horses tend to experience more attacks than older ones, but reasons for this remain unknown. Based on these triggers, some methods of preventing HYPP attacks are to feed your horse several times a day, because lack of food for long periods of time can cause the potassium level to spike up in a situation where they are fed those potassium-rich foods.
So that is an important video for me, because that just describes how difficult it is to detect mutation in horses, and there are diagnostic challenges just with these channelopathies in general. So we're going to move on to the next. Oh, sorry. So this video is one of my favorites. Now I apologize if you have really gone to the Periodic Paralysis Association website and have seen these videos, and apologies ahead of time, some of this is old for some of our viewers, but I do want to illustrate how important it is for us to recognize these attacks, for us to understand them better. I do want to say that there is, for those that don't know about this website and the resources, that this is a great video to show doctors what attacks do look like, because I don't think physicians really see that frequently. And this is just eye-opening and a very great educational tool also to show for caregivers. And so I really appreciated this video. We're going to watch a few minutes, if that's okay, to get a sense of the attacks. And when you're watching it, I do want you to look at it from the lens of a doctor or a caretaker, because the attacks are hard. I mean, there's not complete paralysis, sometimes it's halfway. And so some people just don't understand these attacks. So let's go ahead and show this one.
This is a true attack of familial hyperkalemic periodic paralysis. Triggers for this attack were a high carbohydrate meal and exercise without pre-medication. The patient in this video is a physician and is being analytical through the attack. This attack was amongst the most severe he has had. He is able to speak and is going to lead you through what it's like to be paralyzed.
I've woken up and I'm paralyzed. The first thing that I do is try to figure out how severe is the attack. At least I have my arms, but my hands are very weak, so it's really, I can't even open a bottle of water right now, so that means I can't put my medicine in the water, so that's a problem. And, you know, so now I need to basically call for help because it can only potentially get worse. Well, hopefully I don't have to go to the bathroom, first of all. Sometimes I wake up and I have a little more movement, and so then I can make it to the bathroom, make it to the medicine, call for help, plop back into bed. For some reason, I woke up and I was too paralyzed to do that. So I just have to lie here and basically wait for someone to find me. Once it resolves, I'm gonna need to sleep it off because all my muscles are gonna feel like they're torn up, like I just did a big weightlifting exercise. And then of course you go to work late, people aren't gonna believe you because they don't understand what this is. Luckily, I can, you know, kind of sort of get to my side, and I probably want to stay on my side at this point if I can even feel the remote possibility of throwing up, because then at least I won't choke to death.
Typically, individuals who suffer from periodic paralysis have medication, sometimes pre-mixed, at the bedside, and a phone or other means of calling for help. Here we see typical efforts at movement with a great degree of difficulty. When one attempts this alone, injury, like a twisted ankle, can easily occur.
But what's worse now is I fell asleep over the covers and it's cold, and the cold just makes it worse. So ideally, I'd like to be covered, and I can't even cover myself right now. I'm just stuck here. I really can't move anything right now. I'm very severely paralyzed, so I really need you to pull my arm up. You gotta pull my right hand towards the mirror. You're gonna have to get towards that side because you need leverage. And then, Frank, you're gonna get my leg.
Having a cooperative individual to lend assistance is key. Subtle angles create pressure on joints. The patient is using ergonomic angles to support himself. It is his joints, not muscles, that are supporting the patient. There are risks of moving someone while paralyzed. It can hurt or injure the patient, especially if they are non-verbal. Moving a patient must be decided upon a case-by-case basis. Note that the patient in the video is dependent on the people around him for both physical and psychological support.
Okay, now I need to get the medicine. So you see, I can talk and I can breathe, but I can't move, and this is extremely distressing.
The patient is now taking potassium chloride dissolved in water in an effort to reverse the attack.
At least I have my neck. Sometimes I don't have my neck, and then I'm really stuck. And I think that will happen to me if I don't have the medicine in me. Now, if I drink this fast, what happens is you can get a gas bubble, a sensation that you want to throw up or burp or something. And so I just have to let it happen.
Dosing varies from patient to patient. The patient is taking his prescribed amount.
I think little by little it doesn't work. I need to get a bunch of potassium in the bloodstream quickly to reverse what's going on with the ion channels. Some people underdose themselves and they'll be in this condition for longer than necessary. Now it's extremely tiring for me to stay up like this. At the same time, I don't want to lie down. So what I need to do is can you adjust my feet so that they're both on the floor? And then I want to put my elbows on my knees. And let me lean forward a little bit. Okay, this is kind of okay. See, there's no position that's comfortable right now, unfortunately. So now I'm home, and I'd like to put my arm selection.
Here, the attack is getting worse, as seen by more labored speech and troubled disposition.
I want to lean on Frank. So pull me back up. And let me lean forward a little bit. And let me lean on Frank.
So that's an emotional video because that's really hard to see and to see how things got worse. And I think he had stomach pain right after that. But for those that want to be able to see more about that video and more about periodic paralysis, definitely go on that website. And if you feel that your physicians don't know and you haven't given them my cell phone, definitely show them a video in the clinic because they may not really understand it. So Dr. Levitt wrote this first paper in 2008, and I came across these questions. I did edit a few. I took a few questions that I thought were important, and I added a few of my own. So we really still have not studied as much as we should. So we don't really know who gets permanently weak in the periodic paralysis. Are there risks to chronic potassium administration? We're still learning about that. Does a particular form of potassium work better than another for this disease? And I do tell my patients each individual is different. Some of my patients ask about massage, and does massage make things worse? For some it helps, for some it does not. And so again, that's very dependent on each individual. And should we revise our diagnostic criteria? And that's something that I brought up to the table and I will bring up because things are changing. We need clinical trials, larger groups of patients to come together to answer these questions, plus many other questions that are still unanswered. I'm going to go through a list of the treatments for myotonia and periodic paralysis. You can always come back to the slide regarding doses. So for myotonia, we try things like mexiletine, lamotrigine, acetazolamide, carbamazepine, flecainide, and ranolazine. For the periodic paralyses, we offer things like acetazolamide, diclofenac, also known as Keveyis. And for the hypokalemic periodic paralysis, we try them on potassium-sparing diuretics like spironolactone, amiloride, and triamcinolone. The thiazide diuretics are used for the hyperkalemic periodic paralysis. Those include hydrochlorothiazide and bendorflumethiazide. And then, of course, the potassium supplementation, which can vary from IV supplementation, oral supplementation, and also some patients take it in the form of a drink, or they mix it with water. I do tell my patients, and they've told me, and some of them come up with coconut water, and I tell them also if they don't drink it. For those that are hypokalemic, coconut water is an excellent source of a beverage to help with their potassium. I also encourage fresh squeezed orange juice, not the store-bought, that can be high in calories, but anything that's fresh squeezed usually is pretty safe, and it can help also with potassium. I love exercise, but none of my patients are routinely referred to physical therapy unless they ask for it. Physical therapy can definitely help in terms of helping patients with their limits and knowing how much they can do. But exercise or rest after exercise can be a major trigger of myotonia or the paralysis. And activity is important. So it's really important to balance that activity without triggering symptoms. So some things that have been done in the past are endurance training with a bike. 30 minutes, 3 times a week, which can be helpful. It's really important not to have a sudden contraction or forceful contraction that can trigger the paralysis or the symptoms of myotonia. But just to be very, very gradual. It's okay to have rest periods. It's important to avoid cold and avoid swimming in cold water. Another thing to think about is considering yoga, because yoga has gentle stretching. I know one patient really loves yoga and is doing very well with it. Meditation is important. Stress can exacerbate everything, and of course, our periodic paralysis, our intolerant channelopathies. And some of the meditation techniques out there include mindful meditation that involves being fully present in the moment, in engaging in all the 5 senses and really enjoying every single second and taking away the thoughts that are not relevant for the moment. So that includes focusing on sound and sight and taste and smell and touch. And this meditation helps people not to be overly reactive or to be distracted. This is an important slide as we start wrapping up this talk. Our patients, as I've been saying since the beginning, are going through an uphill battle. Not only is this disease rare, but it's unique. Everybody has different stories. Everyone is different in some way. Patients can have pain. We don't know all the genes. The physicians, you can see how they can get confused. They're still learning. There's a lot of unknowns and variables. And the patient's just trying to get help, just to get the medical care they need. They are suffering with the disease, and then on top of that, going through all these uphill battles to get the help they need. And it becomes hard. It becomes hard on everyone, the patients and the physicians and the families and the caretakers. What we want is we want to have a nice ride, a very pleasant ride. We don't want any more uphill battles. And in order to move this field forward, we need your help. We need to work together. And that's one of the major strategies we have in our clinic, is that we work together as a team to learn more about the condition. Not everyone may have a diagnosis, but we try to help in any way possible. We try to help find new genes. We try to help figure out the problem. We will redefine things together. We'll raise more awareness and understanding of the conditions together. And so that's very important. So I do want to thank you all. This is our team. We have a clinical team and our administrative team and a mix of both. We wouldn't be here. I wouldn't be here speaking today without them, of course, my family at home, and they've been so supportive, and my family at work. They're just wonderful. I wanted to thank you all. We would love to see you at Advent Health Orlando. We do want to work with you to build a center of excellence for you. They'll care for all your needs. We want to take care of you. We're just honored and blessed to be able to have that opportunity. We have already patients from 22 states outside of Florida. If your state is not put on here, please let me know. Text me and say, I don't think I forgot any state, but if I did, just let me know. But we are really blessed to have patients from all over the country get virtual visits, some of them fly in, and we're just more than honored and thrilled to be of any sort of service to help in any way possible. I really want to thank all of you. I want to thank, of course, Linda Feld, who means the world to me, has done so much for us. The Periodic Paralysis Association, they have been wonderful. Every single one, and the board members are excellent, those whom I know. The Strongbridge Pharmaceuticals has been supportive, and all my patients. I've never enjoyed doing this more than anything else. I'm just so grateful for all of you, and I'm grateful for all the listeners here today. And I would love to answer questions. I know that there will be questions at 3 p.m., and I will try to participate in that. So, Linda, thank you.
Thanks a lot, Dr. Jerath. That was wonderful. And I can ask you a couple of the questions that have come in while you have been talking. And we're building up a lot of questions here. Dr. Jerath, this is, I don't know who sent this in, but it says, Dr. Jerath, I have had severe episodes of slowly contracting muscles, usually starting in my legs, to the point of not being able to walk since I am 5. I am currently 72 years old. I have to move my screen down a little. These happen in conditions of a combination of humidity, walking, excitement, and a change in diet. I know how to manage usually, but sometimes these conditions are unavoidable. I don't fit into any category completely. I have read about, I'm not aware of other relatives with this. The question is, as I age, it is even more important to get a diagnosis and to know the exact reason for these episodes. I haven't told my current doctors about this condition, and I don't know how to describe it. In the past, the doctors have not taken me seriously since I don't fit any category easily. How should I proceed? What kind of doctor should I consult? And how should I discuss with my primary doctor so that she will understand? Thank you so much.
Oh, I just love that question. Thank you. We would love to see you in our clinic, and even if you have to do a virtual appointment, I would love to help you figure out what's wrong. And we can discuss strategies on next steps and how to help you with your diagnosis. I also discuss, and I'm always on the phone with physicians, helping them understand. So even if it's a primary care physician, I can help, and I can help educate you as well. So I'll be there for you. If you need to come visit, please make an appointment.
We have another question from Julie. Dr. Jerath, how do we know the difference between periodic paralysis and hemiplegic migraine? I have been diagnosed with the migraine, but it's totally refractory, and my symptoms fit many aspects of PP also. There is so much crossover in symptoms, it seems.
That's an excellent question, and I feel like there will be crossover into the symptoms at some point. But I think that getting your history, I don't have all your history, but getting your history is important. Also, maybe trying potassium to see if that will help you. Sometimes helps with the diagnosis. Of course, genetic testing will help, but starting off with a history is probably the most important thing to distinguish between a hemiplegic migraine and periodic paralysis. Because if you're getting migraines independent of the weakness, and the weakness or paralysis episodes are separate, they may be two separate things. So it's important to spend a lot of time with the history. And that's where I would start. If you want to, again, see me in the clinic, I'll love to help you.
We have a question from Janine, and she's asking about alternating myotonia and paralysis that you're talking about. And she'd like to know, is that the same as myoclonic jerking? This happens to her, and she's learned in the ER that the treatment for it is to be wrapped in heated blankets.
So these things are very hard to detect. I think the myotonia and the myoclonic jerking have to be investigated with certain diagnostic testing during the time it occurs. These are hard. So myotonia is where you have muscle contraction, and then you have myoclonic jerking, which is more of a rhythmic contraction. So you need not only diagnostic testing, sometimes some people will do an EEG to see if the myoclonic jerking is associated with seizures, and then also have a clinician look at it to really distinguish clinically what's going on during those episodes. So these are hard to distinguish. They just need a lot of care. One of the things I do recommend for you is to videotape them. And if you videotape them, sometimes some expert from across the country or the world can help weigh in on their opinion, so you can distinguish the two.
And let's go with one more, Dr. Jerath. This is from Allison, and she's asking, those with excruciating pain, how do they get treatment without being seen as a drug seeker, and how do they get taken seriously?
That's a brilliant question, because that's something I have to deal with almost every week. I'm on the phone with an ER doctor who doesn't believe the patient. Oh, she's coming again. It's that attitude that you have to deal with for some of the physicians across the country who don't understand. So some of the strategies that you can take are, of course, finding a physician who will back for you. I would love to help you out. Number two is that some of my patients have written letters. to the ER doctors, have letters signed by a physician who's going to support you. The letters will say, regarding this patient has this, and I assume, I don't know if you have a diagnosis of periodic paralysis or a myotonia, but some of my patients say, okay, they have this channel lopathy, they have this known mutation, and they will experience pain, and for this pain, they need these next steps to be taken. And that really helps our patients get the care they need. So it's important to get a physician who's going to understand it, and then as well get a letter that will help you. And then if that doesn't help, and you go to some unusual ER that doesn't know you at all, then my patients immediately give myself up. So I know that I've used to help my patients, but not everybody has that ability to get a doctor to give their cell phone and respond at all hours, at 9 o'clock on Friday, sometimes 3 a.m. in the morning. It's any time. I'm so grateful to be in this position to help, but I'm really writing a letter, getting a letter from the physician, that can help you.
Well, thank you so much. Dr. Jerath is my doctor, and I can't say enough about her. I think she is wonderful. Thank you so much for being here today. And we're going to be changing presenters now. And the next presenter is going to be Laura Russell, who also works with Dr. Jerath in her office. So we'll see you later this afternoon, Dr. Jerath, when Dr. Cannon is answering questions.
Perfect. Thank you so much, Linda.
You're welcome.
Do I need to do anything to get off, or?
I'm changing you.
Oh, perfect.
I think I'm changing anyway. Just a second. This is the first time, everybody, so you're going to have to bear with us. Our next presenter is going to be Laura Russell, and Laura Russell is a licensed clinical social worker. She has a bachelor's in social work and a master's degree in social work from the University of Central Florida. Laura is a qualified supervisor and able to support and mentor registered social work interns in the state of Florida. Laura started her career helping children who have experienced abuse. The last 7 years, Laura has worked with patients and their families who have chronic, terminal, and end-stage conditions on adjustments to illness and coping with the emotional impact. Laura is currently the licensed clinical social worker with Advent Health Neuromuscular Medicine in Orlando. So she works with Dr. Jerath. And Laura, I'm turning the screen over to you. You should see something come up on your screen.
Let's see. Can you hear me?
We can hear you. I think there you are.
Hello. All right. So let's see if I can share my screen. I think you did it for me last time.
Yeah, I think your screen is shared. The emotional journey of periodic paralysis is up on
you
the
can
screen.
see it. All right, great. Let's see if I can get it to presenter mode. There we go. Did that work?
It did.
All right. Thank you so much for that introduction. So like Linda said, I'm Laura Russell, and I am a clinical social worker, and I work with Dr. Jerath in our Advent Health Clinic. I'm going to kind of shift gears a little bit and get you thinking about the emotional journey that is PP. And what I mean by that is I would really like to focus on the psychosocial aspect, because we really can't treat any of these medical conditions without first, of course, focusing on our psychosocial impact that the diagnosis comes with. This will be kind of the agenda that I will go through. And if you can see, I'm going to explain first what a social worker is, because I know there's a lot of misconceptions and I want to kind of clarify that just a little bit. And then we will touch base briefly on the medical, psychosocial, and of course, that mental health impact. And then I'm going to, of course, want to touch base on coping and some of those stress management skills. So I leave you guys with a little bit of tools to kind of attack some of these different concerns that come up along the journey. And I will spend a little bit of time touching on our caregivers. They are the backbone of our healthcare, and I want to make sure I give some very strong attention to you guys. And then I would like to close with talking about how Advent Health is now responding to our PP community and what I'm going to be doing to really target you guys and make sure we are being inclusive in care. All right. So what is a social worker really? So like I said, I know there's a lot of misconceptions on what we do, and I'm a big advocate that any medical discipline should have a social worker on staff. So social workers are master's level mental health clinicians. So we are trained in understanding human behavior, and specifically social workers, we like to target the social environment. So not only do we focus on the psychological, the mental health impact, but also the environment that we live in. So when I talk about psychosocial, I mean the psychological aspect as well as the environment. So when I'm with a patient, I want to acknowledge everything that goes on in their community, as well as in their home, as well as internally. Social workers help navigate the emotional challenges that come with this diagnosis, as well as any chronic illness. We can't really treat a medical condition without considering those psychosocial and psychological impact. My philosophy is I really like to do a patient-centered focus. So when a patient comes to me and has a concern, my first question is, okay, tell me your story. We don't always need to start from the very beginning, but I want to hear what is going on with you today, yesterday, and really help formulate a strong rapport and relationship so I can know not just what's going on physically, but really what's going on internally and how has your environment been impacted by this condition. Social workers are a big facilitator to aid in a patient's self-empowerment. I strongly believe all of our patients, and anyone for that matter, has the power to really have a positive mindset and attack a lot of these conditions emotionally. And we just have to kind of dig out and find that self-resiliency that you have. And of course, social workers are big advocate for social change. I know a lot of our patients are adjusting to this disease state, targeting and educating the medical community, and it's a lot of work. So social workers really want to be in your corner and being the advocate along with you. And of course, as you know, there is a limit for resources. So social workers are always constantly researching and looking to see what is the most available resources out there and how can we really make sure we are bringing the most benefits to you guys. So that kind of is a brief synopsis of what a social worker is and what we do. I would ask that any of our medical team listening today is if you don't already have a social worker on staff or a part of the team, I highly recommend it because like I said, we really can't treat anybody medically without acknowledging this major aspect of their care. Because if we just fix or adjust or treat that physical pain, that does nothing for the rest of their environment and how their relationships have shifted from getting this diagnosis. And we'll definitely talk about that throughout my talk today. All right, so I know Dr. Jerath kind of touched on this briefly with the medical impact. And when I say that, I'm talking about kind of more of the social aspect of my entire talk today. It won't be really medical minded. So really the accessibility to specialists. I know Advent Health, we are taking patients from all over. We want to make sure we are targeting anybody who is in need. You can reach our office because I know there is a limit on the availability of neuromuscular physicians or medical teams that really understand PP and the components that go with it. I know a lot of you struggle with the financial piece that comes with PP. Do you still have access to insurance? Do you still need to apply for Social Security? I know that's a very big factor, and we'll touch on base on that as well. I know most of my patients, one of their first things they express to me is the frustration that they have experienced during a hospital stay, most importantly, an ER visit, if they make it that far. I know one of their biggest arguments is, I'm constantly having to fight for somebody to listen to me, to hear me out. And if they do, then there's that fear of being misdiagnosed, of being not being believed, or being over or under medicated. So those are some big factors that we have to make sure we are acknowledging during this process. And of course, one of the biggest challenges is finding the right medical team for you. You can have the best team of specialists, but it might not match your personality or what your goals are. So we definitely want to make sure we're acknowledging that. And there's also a limited for resources. If you live in a rural area and there isn't a specialist near you, then you have that barrier. Luckily, Advent Health, we are trying to break down that barrier and make sure we can bring access to you guys via telehealth visits. So that is just one little impact that we're trying to make. All right, so this is probably one of the most important aspects, and that's the psychosocial impact that PP has on our patients. And the actual literal breakdown for psychosocial is the psychological, which is typically your mental health disorders and such as that. The second is the social. So your social environment, your relationships, your life with work, how you cope with your natural environment, your culture. How do these aspects of your life play into your healthcare? So my big role as a social worker is to make sure I am advocating for your psychosocial connection and issues, to make sure we are really targeting those losses, changes, or needs in your care. So I listed a couple here. So a change in the family role. So you may have been the breadwinner or working full time, having this high, fast paced career, and then you start getting these symptoms and it starts changing your dynamic. Fatigue, you can no longer attack work like you used to. And that comes with a lot of barriers and stress. And we want to make sure we are addressing those concerns. Um, another big one really is difficulty in mobility. So maybe you've gotten a motorized scooter. Great. But your home still isn't accessible, right? So then we have to go through that process of making sure your home is safe, accessible for you. And then you have the added layer of, well, what about the world? When I leave my house that's accessible for me, everywhere I'm going to go, is there going to be a barrier? Am I going to have to practice or plan different grocery stores or different stores I'm allowed to be in based on the access? So that is really the big impact that we see, is not only do we have the concern of physically how am I getting treatment, but how has my world now adjusted with this diagnosis? Even a change in relationships, that's another major factor, because relationships get impacted, whether that's your best friend doesn't understand your diagnosis and they constantly question, well, I just don't understand. And you feel the pressure to fight and impact yourself or empower yourself to be able to say, well, this is what I'm going through. And it's hard when you're constantly having to have that talk and fight for your diagnosis and explain your symptoms that are very difficult on a science level to understand. Never mind express that to somebody who doesn't really have the experience as well. So marriages get impacted, friendships, children, and it's also important to mention that we might be uncovering a genetic condition that nobody has known about. And then you start thinking, well, maybe this is something that other family members have been impacted or the other community. And you want to make sure you are making those connections so you feel safe and you have other people to talk with. Another big one that I wanted to mention is the Social Security disability. So I know we have people from all over, so this really would be pertaining to, of course, the US for my experience. But our process for SSDI is, oh, it is borderline impossible, right? So my biggest thing is once you get the diagnosis, it's so hard to prove the other that is on Social Security. So then we have to worry about the impact of loss of income or change in job level. And that is a huge barrier that I focus on with my patients and walking through the process for SSDI and making sure I'm a big advocate for you as well. Now, the mental health impact, and I definitely want to preface this part with saying I know there is a very large stigma attached to mental health issues with PP, and I don't want to minimize the stigma that a lot of our patients have to break down because I know experiences of going to the ER, a lot of doctors or staff members might say, oh, I think this is a psychological concern. I don't think this is physical. I don't think this is an actual diagnosis, and really pushes the mental health talk. So I know that's a barrier for you guys, and I want to make sure that I'm also breaking that stigma down as well, because none of us are immune to the mental health impact of a chronic illness or a diagnosis or a mental illness without a medical condition. So it's really important that I stress this to you, that I'm not trying to minimize the difficulty you guys have to go through to say this is a real condition. It's not just psychological. But with that being said, it's also important to know that this is a side effect that can happen because of X, Y, and Z of what I just said, of everything you're fighting for. It's just natural that our body goes into overdrive and we have a mental health concern develop. And people with chronic illness are at a higher risk for developing a mental health concern because of the fight and the stressors that you guys get put under, and we all do. And I did find in my journey of really targeting mental health and PP that there is a very significant limited research out there for PP and mental health. And that's really important to note, because are we not targeting this population and making sure everyone is being cared for in their emotional state? And then that goes back to me saying, I think a social worker should be a part of everybody's team, so you're not alone in that aspect. Um, I really wanted to briefly mention the medical model versus social model. The medical model you guys are probably very familiar with. That's where our focus is on finding a cure, the research, and really making sure we can treat certain conditions. Well, now we are starting to look at the social model. And of course, myself as a social worker, I'm a little biased. I am a very, pro social model, because I want to make sure we are taking into consideration that psychosocial aspect of your life when we are talking about PP. And I'm going to read this quote because I just find it so, so beautiful. It is from the Social Model of Disability and Chronic Disease. And it said, it was from Lois Keith. Doing disability all day long can be an exhausting process. I don't mean having an impairment. In my own case, not being able to walk. I think I just messed up my screen. Sorry, guys. So I can deal with, I mean having to spend a majority of each day with a physical world which is historically designed to exclude me. And more tiring, dealing with other people's preconceptions and misconceptions on me. That is such a huge, huge quote that I think is so very important that we all embrace, because it's true. A lot of our patients with PP will be successful and adjust with this diagnosis. It is a challenging and difficult road, absolutely. But what makes things more difficult or more tiring is trying to deal with the outside world. So while I may be diagnosed with PP, right, and you get accepting to the point that I'm like, I can do this, I know my triggers, I'm prepared and planned for an attack. But what about the world around me? How will my relationships be impacted by that? How will my loved ones recognize if they feel that I'm experiencing one of these attacks? How will the ER staff treat me if I need to go for emergency care? How is my van or these restaurants or shops going to be accessible for my diagnosis? So it's not only having to cope with yourself, it's the world around you. And I think that is really what brings me to talk about the next three disorders that can often develop from this preoccupied thought of all of these different things going on in our lives. Anxiety is probably one of the biggest factors, and anxiety is going to be at some level completely normal for all of us to experience. Um, it is really, really what helps us stay on top of tasks and making sure we achieve our goals, because it keeps us focused and really keeps our heart pumping to make us really follow through with things that we need to do. The difference with actually an anxiety disorder and this normal level of stress and nervousness is when anxiety becomes so severe that it's preventing you from doing your favorite activities or daily tasks, and you have more often than not a real sense of uneasiness, distress, or dread for any of your normal activities that you have. So, for example, if you are preoccupied with your next attack or a next symptom that might happen, and you can't get out of the bed for the day, or you won't leave your house because you're just so worried something might happen, then that is something that we would want to target and really make sure we are addressing so it doesn't consume your life. We never want that. It's treatable, and we want to make sure we're addressing that. All right, and some of the big symptoms of anxiety disorders, we look at restlessness or feeling keyed up or on edge. And what that means is that's that really nervous feeling where you start getting maybe clammy hands or nervous, or your body kind of heats up and you really just can't get comfortable, and you're just preoccupied with those thoughts in your mind, kind of on replay. And if you're being easily fatigued, and I know that's kind of ironic with this diagnosis because that's very common. So when I say easily fatigued, it's going to be you're just kind of emotionally exhausted from the day. So you just sit on the couch and you're like, oh, I cannot think about anything anymore. And then difficulty concentrating or your mind going blank. If you find that you are becoming so nervous or anxious that you kind of just shut things out or shut things down, or maybe put a wall barrier between you and everything else going on, then that might be something of concern as well. And then sleep disturbances is something we see with PP often as well, and with any chronic illness for that matter. So if you're having difficulty falling asleep, staying asleep, or really having that unsatisfied sleep. And this is a big concern I see with our patients with PP, because a lot of these attacks really cause that nervousness of going to sleep, maybe waking up in, a paralyzed motion or having that kind of barrier. We want to make sure that we are addressing that in a psychosocial manner. And there are certainly treatment options for that. I'm not going to talk about a whole lot of treatment, but I will give some coping skills and tools for that. But of course, cognitive behavioral therapy is one of the options. And, I will love to talk more on this at a later time. And depression, which is the persistent feelings of sadness and hopelessness and a loss in interest in activities you once enjoyed. Now, we all kind of experience sad mood and difficult hardships that come and go, and that's going to be normal. Life is not easy, it's tough. So, when I mention depressive disorders, I'm really talking about the extreme. So, where maybe you once loved playing soccer or playing a computer game, and those things are no longer of interest. You don't have the motivation to want to get up and engage in your normal activities, then that might be a concern as well. If you are really feeling down on yourself or really giving yourself a hard time for these difficult challenges, and uh, I really wanted to mention the sex drive change because that's so important. We want to make sure we are treating the person holistically and targeting all different areas, especially extreme mood change. I know we can go through periods of anxiety or feeling really sad or feeling low. And we want to make sure we are targeting all of these different areas. We definitely have the diminished ability to concentrate, or we I guess a big example would be when you are kind of wanting to stay to yourself. Maybe you're not engaged in all of those activities you once enjoyed. And those are really, really important that we address all of those things because we want to make sure you have the best quality of life that you can. And um, that kind of brings me to PTSD. I know Linda and I both really chatted about this, and this seems to be something we see often with our patients, which is the post traumatic stress disorder. And typically, we relate this or we think of this as a wartime thing or a loss of life or something very tragic has happened. And that's absolutely true. But what I want to relate PTSD to with our patients is that medical experience and what happens when we go to the ER and we're not being listened to, we're not being heard, and we have these periods of patients are fighting constantly for being heard or acknowledged. And that is really stressful on the patient. And that can bring back up old memories of maybe you were admitted to the hospital and you didn't feel that your care was being understood or appreciated, or you weren't being acknowledged. Later down the road, if you have to go back to the ER for more treatment or back to your medical team, and these different uncomfortable emotions come back up, and you get these flashbacks of experiences, it could even be anxiety inducing. We want to make sure that we are being careful of that, and it is definitely treatable with a licensed professional. We want to make sure we are listening to you guys in these experiences. And PTSD, of course, is in the DSM-5, which is the Diagnostic Statistical Manual of Mental Health Disorders, and that really breaks down what the symptoms are and things on that. All right, so that kind of brings me to coping with chronic illness. And we all use coping strategies at different time periods, and we might not even know we're using a coping mechanism. Some are positive, some might not be as positive as others, but they're definitely our way of using defense mechanisms and really kind of protecting ourselves. And Lazarus and Folkman are psychologists, and they really kind of, I appreciate that they broke it down into two different levels. So we have our emotional focused, which is kind of our own reduction of negative emotion to stressful events. And then we have problem focused, which tries to target our stress in a practical manner. So problem solving or actively trying to work towards managing a stressor. Now you might say, well, no problem. Problem focus seems easy. We're going to target the problem that we're experiencing and really focus on addressing those triggers that we might have for our illness, or changing the problem that we're facing, or how can we plan for an attack to occur so then I can diminish my fear or my anxiety surrounding those concerns. Well, sometimes those kind of problem solving techniques don't always work. For example, if we have a death or a loss in the family, sometimes compartmentalizing those into that kind of a category doesn't really work. We can't simply problem solve a big loss like that. Or, like I said, getting diagnosed with PP, that is a life-changing diagnosis that we really have to make sure we are addressing everything surrounding that. So that's where we kind of look at our emotional focus. How can we make sure we are reducing the negative emotions that can kind of go with it, and we can really learn to cope in a safe, happy manner. Some of us are, very good at staying in the denial phase. We're like, we're just not going to address it. We're going to keep going and ignore certain symptoms that we see so we don't seek help. Some of us avoid problems altogether, and those are coping strategies. They might not be the best healthy way, but it's certainly ways sometimes we protect ourselves. All right, so I would love to touch base on some positive coping skills and what tools I would ask that you guys try to utilize. My biggest one always is really try to find the humor in life and maybe not always take it so seriously. We want to make sure we still find joy in the simple things, laugh at ourselves when we need to. Maybe even poke a joke at it at sometimes because it's really important we don't make everything so serious and that we really take time for ourselves. And like Dr. Jerath said, physical activity is very important. We want to, of course, keep in mind some of the expectations that we don't want to push too much on our patients. We want to encourage activity, but as well as it's okay to rest. And that's just as important for a coping skill as well. Do a little bit of physical activity and then also be easy on yourself and allow yourself some time to rest as well. And then reading. I know a lot of us spend a lot of time focusing on our research and reading as much as we can on PP and symptoms and concerns in that sense. But I also ask that you find material that brings you joy, kind of can transport you to a different environment for a little bit and just get you focused on different things. We don't want this to consume your entire life. You are still a person and identity beyond this. And that's really important that we want to make sure we are treating in that sense. And of course, surround yourself with people you love and who love you. Find the community that really embraces your individuality and the conditions that you experience, but also will walk side by side with you and make sure that this journey is inclusive and together with you. And then, of course, we definitely cannot forget our spirituality. I know this is different for every single one of us, but I request that you guys all find what is internal to you guys and what faith or spirituality or higher power that you find comforting and really embrace that because it's so important that we utilize a team approach with coping with life and all of the barriers that we face. All right, and stress management, which is very similar to coping, it kind of goes hand in hand. Stress management, on the other hand, is really actively working toward reducing the stressors in your life. And what I mean by that is making sure we are decreasing kind of the outside noise of life and everything that goes on with it. A lot of our patients are struggling with lifestyle change, role change, decrease in working, or maybe us continuing to participate in a demanding job, or even for some of our younger patients, our relationships at school and having to navigate growing up. And there's so many life factors that hit us really hard that it's important that we slow down and take the time to really decrease some of this outside stress. And I put 5 main things that I really thought were important because there are thousands of techniques out there. And when I work with my patients, I really try to see what will match their personality the best. What if they tried in the past that worked well? What didn't work so well? And how can we individualize our plan of care? Keeping a journal is probably one of my absolute favorites. It gives yourself a chance to write down your emotions and what you are feeling from the day and really make sure you are in tune with how you feel. So, say I'm feeling really angry today about my diagnosis or a symptom that I'm feeling that just won't go away. I want to document it in the journal and then put it away and then go back to it and allow myself the ability to process those emotions that I was feeling. And then I know Dr. Jerath said this as well, practice mindfulness. You embrace the meditation or breathing techniques. And you can use this, there's a lot of good material on Google, but you can also find YouTube videos that really kind of walk you through that meditation as well as a professional, because it's so important that you take time for yourself and really be in the moment. And then, of course, if you can start to acknowledge a lot of your trigger warnings, and this isn't necessarily trigger warnings for medical aspects, but for mental health concerns, for anxiety, or if you feel that you are experiencing some of those PTSD moments where you are having those flashbacks, I definitely want you to write down those trigger warnings and really learn to target them and kind of redirect your behavior and your thought process in that way. And sometimes, and most often, it does take a professional to aid you in that. And then crisis plan. So I know that sounds kind of silly, but if you anticipate these different crises or concerns coming up, then you can plan for how you will attack them. How will your support system jump in and help you? If your plan is to call Linda, I know that's often, and you need other referrals, definitely plan for those phone calls. Who are your top 3 people you notify when you are having a stressor and you need some assistance? Have that in place so it can ease that burden of that crisis mode. And then focus on things that bring you joy. Make sure you are still out living and enjoying all the things that life has to offer for you. And this is kind of my biggest thing that I want to express is stay involved in your healthcare. You absolutely have to be your biggest advocate. And I hate that that has to be that way because you would want your team to fight and fight and fight for you. And I know my team, we absolutely want to make sure we are treating you as a whole individual and in a very holistic approach. So, what I ask is that you be the leader of your plan of care. And what plan of care means, it's really what your goals and expectations are for your treatment. So be upfront with your provider on what your expectations are. Bring your questions when you go to that first appointment so you can make sure you have everything written down and you are prepared to have that open conversation. Stay up to date on all the latest research that you can. And I don't want you to become consumed with it because it's just a portion of your life, but I want you to make sure you are still participating in that aspect. And then, of course, continue to ask all these challenging questions. We may not always have the answer for you, but as long as they are being brought up, research can be done. We can compile all of these questions and really build the repertoire to be able to address these needs across the board. And then my biggest thing is, share your experiences with others. This can be a very isolating diagnosis, and it's important that we make sure you know, and we all know that we're not alone in this, and that it's important that we are addressing everybody. And you can do this from getting into support groups and sharing your story. I know I love to hear the story that my patients have been experiencing so I can have a better understanding on how I can then meet the need that they have. And before I change the slide, always take the opportunity to educate others. And I know it can be very tiring, but we want to make sure any even medical professional or anybody in the community, educate any chance you get. That's why I started my slide with educating on social workers, because there's a preconception on a lot of this, and it's our responsibility that we get the word out so we can ensure all of our patients with PP are treated fairly and get the right treatment that they deserve. And then this kind of brings me to getting the right help. So number 1, make sure you're being kind to yourself. Talk with your provider and your team and make sure they are the right match for you. And if it's not working, don't be afraid to say something or to seek other opinions. That's definitely important. And you have to advocate for your care. If you leave an appointment and you still have questions, maybe contact your social worker to clarify and to really partner and make sure we are reviewing that plan of care with you. And then ask for help when needed. Seek that peer-to-peer support. So join different support groups. I know, and I will talk about this towards the end, I'm going to be trying to start support groups as well, so I can make sure the patients who come in contact with our clinic definitely get that support as well. And then seek mental health treatment when necessary. Talk to your social worker, get a private counselor. see a psychologist. It's important because none of us are untouched by mental health concerns. And it's understandable that with all of these barriers and stressors that, patients get put under, that one of these might develop. All right, so now we're going to shift almost completely to talk about our caregivers. I really didn't want to have this talk today without mentioning all of our caregivers. Truthfully, they are the backbone to our healthcare system. And I don't think our caregivers get the acknowledgement that they deserve, because we as a healthcare system literally couldn't function without our caregivers. And this is unpaid caregivers, paid caregivers, but really our unpaid caregivers keep us, really in business and working, because without them, there's a whole gap of care that is completely missed. And we kind of practice under the assumption there is somebody there to assist our loved ones. And some of the concerns that we see from caregivers, because remember, they are regular average people, just like our patients, just like any of us. They are not immune to mental health concerns, or I know oftentimes our caregivers kind of neglect themselves. Their focus is on our patient, which is great, but then sometimes their own care takes that backseat a little bit. And we have to acknowledge that our caregivers are also grieving a lifestyle change when these symptoms start occurring. So maybe we have a husband and wife, and they were getting ready to retire, and they had these big plans to travel the world. And now their life is kind of consumed with understanding these new symptoms that we are seeing. And now they are grieving what their plans were going to be, and things have shifted. It's important to acknowledge that and work through it as a partnership. And even if we look at our parents, who are the caregivers to maybe our younger population, or even our older population for that matter, it's important to see how things have shifted. And I know a lot of my caregivers express frustration with, I just want to be able to have a cure out there for our loved one. Or they wonder, well, why wasn't it me that this happened to? Why was it my other family member? Or why was it my son or daughter? And those are real stressors and real concerns. And we want to make sure we acknowledge those and address them and support you the absolute best that we can. And being a caregiver can be quite isolating, because you might feel the internal need to be nearby your loved one and be able to be attentive, that you start to slowly change what your normal routine used to be. So you cancel some of those maybe bingo night or those other appointments that you used to do for fun, because your life has shifted. And we want to make sure that we really focus on the dynamic of both parties involved in this care. Now, how do we care for our caregivers? I know that sounds, like, oh, you're absolutely right. How do we make sure we are keeping our caregivers healthy, well, and able to continue to do their role? Well, we want to make sure we have our caregivers practice self-care. And what self-care is where you take a couple of, minutes, hours, days, for periods to yourself and do activities truly solely for you and what brings you the most comfort. Whether that's sitting outside in the morning having a cup of coffee, or reading a good book, going and getting your hair done. All these different little things that a lot of us think are just routine care, sometimes our caregivers really push those things to the side. We want to make sure we are continuing that. And also make sure you are taking care of yourself physically. That is so important. I think that is probably the number 3 thing that my caregivers say is, I'm not even scheduling my own appointments, because we are really focused on making sure my loved one is getting all the attention they deserve. And I know that's a big barrier as well. So we want to make sure you are still taking time for your own health care, because we don't want you to kind of feel neglected in that sense, and also have your body physically deteriorate as well. And then we want to make sure we focus on the communication between you and your loved one, because that is probably a big concern with our patients and caregivers. Our patients, I know they tell me all the time when we talk in private, how can I express the gratitude that I have for my caregiver or my partner? How do I express that I couldn't do life without them and that I'm so appreciative? So, communication is going to be so important that we practice our I statements versus you statements. And I mean to say, if you're having a bad day, say, I'm having a really hard day. When you talk to me that way, it hurts my feelings instead of saying, you're being rude in that kind of sense. So we want to make sure we acknowledge our emotions and we really open that dialogue so everybody can share how their emotions are impacted. And then I did write down date night, but I don't necessarily mean that in a romantic sense. It could be between an aunt and his nephew or cousins. Really make sure you are still keeping that level of relationship that you guys had prior to adding chronic illness into the household. So, what were some activities you guys all enjoyed? Make sure you still find the joy in life and you continue that partnership. Don't build a wall where it's you're the caregiver, I'm the one who needs help. Really be a partnership. I know the community is now shifting caregivers to care partners, and that's actually a great way of saying that because that is really what we are. It's a partnership between two people or a family system, and we want to make sure we are doing that. All right. This is going to be kind of where I really shift to talk about what Advent Health is doing for our PP community. So, like I said, I work with the Advent Health Neuromuscular Medicine Clinic with Dr. Jerath, and I am the clinical social worker for the team. And my role kind of has two different goals in mind. So, number one, I am working in the clinic and I will attend all specialty clinic days. So I provide emotional support and individual counseling where needed. I make phone calls to our patients to make sure they are staying up to date on their care, and we are really making sure we are managing their stressors and keeping them emotionally supported. The second part of what my role is to talk about the Neuromuscular Powers program, which is what I am in the process of developing with Advent Health. And what POWERS stands for is our programs for outreach, wellness, education, resources, and support. And my goal is to make sure we are building our community for our neuromuscular programs through outreach. And what that is I'm going to bring to a kind of our community different webinars or in-person support groups to really target our emotional needs as well as our educational needs. So I will be hosting different programs where we have guest speakers from all over the nation that will come. So kind of like a mini conference, if you will. So we will have guest speakers. I really want to make sure we are targeting different age groups for support for PP. So that'll be in the works as well. And really learning to and helping our community navigate different resources and programs in that sense. All right, let's see. All right, so my biggest hope that you guys take away from today is that none of us are immune to emotional or psychosocial concerns, and that it is so important that we all take the time for ourselves and really listen to our bodies and acknowledge that we're on this emotional journey together. You have a team in, your back pocket. You just reach out to us and we will definitely be there to talk you through any kind of dynamic or concern that you feel there's coming up. I know a lot of us really have concerns with research in the medical aspect, but I challenge all of our medical team who is listening today to get a social worker on staff so we can treat our patients truly holistically and inclusive and make sure we acknowledge their cultural backgrounds, their emotional needs, as well as adjusting to the illness itself. It is so very important we really acknowledge everything. All right, and I think that kind of concludes my talk for today. I'm not sure if I know how to get out of this to my screen.
We'll get you out, Laura. Laura,
there you
don't
go.
worry about it. You really epitomize the motto of the PPA. You are not alone. So
Oh,
thank you so much.
you're so
for
welcome.
being
I don't
here
have a
today.
fancy background that you guys have.
Oh, this is courtesy of Strongbridge. So thank you, Strongbridge.
Absolutely.
But
Well,
thank you today. I'm going to be taking your camera away, and we're going to be moving on with Dr. Bell here in
thank you
just a
so
minute.
much.
Just a second, Dr. Bell will be coming on, and I'd like to read a short introduction about him. Dr. Bell attended the University of Arkansas for Medical Sciences College of Medicine for medical school and completed his residency at Duke University Hospital. He is currently, let's see, I lost my place. He is certified by the American Board of Pediatrics and was also a fellow for the American Academy of Pediatrics. Dr. Bell practices in Amarillo, Texas, and has become an authority in the field of treating children under the age of 18 with various channelopathies. Since moving to Texas Tech, he has served as the Infection Prevention Medical Director for Northwest Texas Hospital and Director of the West Texas Influenza Center. He works closely with state and local public health agencies. He is the Regional Director of the Center for Tropical Medicine and Infectious Disease and Regional Chairman of the Department of Pediatrics in Amarillo. He works with an international collaboration in influenza research, as well as pursuing research interests in epidemiology and dysautonomia. I think you can all relate to how busy Dr. Bell has been during the coronavirus epidemic, and we thank him for making this time to join us today. So just a minute, and I will get this over to Dr. Bell. I think. Dr. Bell, can you hear me?
Yes, ma'am.
You can hear me. Here
we go. Share my webcam.
Yeah, there you are. I'm gonna bow out now for a while.
Okay, and I am a Luddite, so it's likely that I'm going to mess something up from a technology standpoint. I've already done it once this morning, so please don't abandon me here.
We'll be in the background.
I will try to show my screen, and there's a button that says that.
There is.
Not sure that it worked, but I did press the button. Let's see here. It does. Oh, yeah. So Linda, is that, can you all see my screen?
Yes, Dr. Bell, we can see it.
Excellent, excellent. And out of curiosity, because I had a video that worked fine at 10 o'clock last night and didn't work this morning. And are y'all also able to see me?
I can see you. I think everybody else can too.
Excellent, excellent. Because we'll do a little live demo here in a moment. I really appreciate the opportunity to be here, and everybody's. Oh, sorry, just a second. I just lost my screen again. appreciate the opportunity to be here and everybody's patience with me as I try to work out the subtle details of the computer here. I need to be able to see my own. Linda, do you recall which button I pushed to minimize myself?
To minimize yourself, you're pretty small at the top of the screen now.
Okay. I can't see the this actually worked fine.
You can't see your slide?
Yeah, I can't see my slides.
Uh,
Oh, here we go. How about this? Let's see here. Hey, there we go. All right.
now you're big.
Can y'all still see me?
Yeah, we can still
right.
see when we see the COVID-19 for the periodic
Perfect.
paralysis patient.
Excellent, excellent. I think we're on a roll then.
Okay.
So I really do appreciate everybody's time. I recall that the last time you guys were gracious enough to allow me to speak. I think I ran over by about 30 minutes. So I've actually a timer, and we'll kind of run through. You know, just in case anybody has been in a coma for the past 12 months, we'll try to get you up to speed. There's a pandemic going on. It's caused by a virus. And we get a lot of questions about COVID-19, and obviously with the PPA conference, part of our concern is, well, how does that specifically affect our patients who have channelopathies and periodic paralysis? And so that's kind of what we're going to talk about here for a little bit today. I think there's a, first of all, I don't have any commercial conflicts of interest. It's worth remembering that I'm not a virologist, and perhaps more important than that is the concept that science is never complete. We know that with periodic paralysis, we certainly know it with dysautonomia, and when we think about what's going on with the pandemic, what we're seeing is that every day we learn something new and different, and our understanding tends to evolve. But what I'd like to do is to be able to review just some of the basics of COVID, as well as speculate a little bit on potentially COVID and periodic paralysis as a diagnosis. Now, I'm reminded a little bit of the rhyme of the ancient mariners. There's a, if you recall in the poem, there's a boat that is floating across the ocean, and they've run out of fresh water, and they lament the fact that there's water everywhere, but there's not anything to drink. And when we think about that in the concept of the pandemic, it seems like that we have data everywhere, but we're struggling to figure out what to think. We actually have seen that with the coronavirus pandemic, this truly is a science in real time phenomenon. So we've seen that if you look at the decade prior to 2019, there's about 700 articles per year on coronavirus, because obviously coronavirus is not a brand new virus. We just have a new strain. In 2020, we've averaged 1,000 articles per week. And so things that I say today, our understanding may evolve as time goes by. Science is rarely simple, and it's often messy. And so there's things that I may say that people may disagree with. I'd guarantee that anything that I say today, someone can pull up some kind of article that would be an argument against what I'm saying. But in general, we're trying to look at the overall preponderance of evidence to try to make our best guess as to the what's our understanding. So first of all, very briefly then, this is a virus and not a bacteria. For those of you who are English majors, we'll just kind of run through some of the basics there. First of all, a virus has to get inside a host cell, as opposed to bacteria can multiply outside a host cell. That's the reason that we have people can get salmonella from a dirty wash rag, and if the dirty wash rag that they used or that was contaminated with chicken is sitting in a warm, moist place for a while, the actual burden of the bacteria will actually increase, because salmonella is a bacteria and it doesn't have to be in a cell to multiply. Viruses, though, do have to be in a cell. Antibiotics work against bacteria, they don't against viruses. Viruses are certainly more common than common causes of infection than bacteria. And there's, just as some examples, we think about influenza A causes the flu, that would be a virus. Adenovirus causes a sore throat, that'd be a virus. And in this case, SARS-CoV-2 is actually the name of the virus, and that's what actually causes COVID-19. So there's actually 4 groups of coronaviruses. The first 2, and alpha and beta coronaviruses, are the ones that actually cause infections in people. And again, these have been around for a long time. I think it was back in the mid-60s, if I remember correctly, that coronavirus was first identified. And the alpha coronaviruses typically cause a common cold. So the beta coronaviruses are the ones that we've seen causing outbreaks that have the potential to create pandemics. Now, COVID is not actually the first beta coronavirus outbreak that we've seen. There was something called SARS, which was back in 2003, 2004, if I'm remembering correctly, and it was actually very similar to COVID-19. It just didn't spread as well from person to person. In starting just probably about 10 years ago, we actually had an outbreak of something called MERS-CoV, which was mainly in the Middle East, and it actually seemed to be associated with camel exposure. And MERS-CoV also caused significant illness, but again, was not able to spread easily from person to person. Obviously, COVID-19 or SARS-CoV-2 is a little bit different in that it seems to be very well adapted to be able to spread from person to person, but all of these are part of the beta coronavirus family. So it's an RNA virus, it's not segmented. The only reason that matters is that there's some types of pandemics that are driven by segmentation of the virus. It has sort of an average mutation rate for RNA viruses. So you'll hear on the news about that the virus is mutated. All viruses mutate, and RNA viruses tend to mutate faster than DNA viruses. But COVID just sort of seems to be on average for RNA viruses, certainly not as fast of mutation as what we see with the flu or with HIV. It also, these viruses in general tend to be temperature sensitive, meaning that heat tends to kill off the virus pretty easily. And so that gives us some ideas when we think about decontamination protocols and things like that. And then I think the last thing to remember is that there's lots of different host species for coronavirus, so that we actually see that this particular coronavirus we think probably originated in bats, but we actually see that cats can be infected. Interestingly, probably dogs, maybe not quite as much. Mink, if you happen to live on a mink farm, then you're really kind of in a difficult situation right now, because minks are certainly at risk of coronavirus infection. When a virus tries to invade a cell, a human cell, remember it's got to get inside the cell in order to be able to replicate. The way that it does that is initially by being able to bind to different receptors, and these receptors are very specific. It's not able to just pick any receptor on the human cell to be able to bind to. In this case, it has to bind to something called an ACE2, and that allows the virus to be able to basically join with the cell membrane of the human cell and inject the contents, specifically the RNA, into the human cell. This is actually a cartoon graphic from back in 2014, based off the original SARS-CoV, which was the original SARS outbreak back in 2003, but it still illustrates the point of the ACE2 being the receptor that it has to be able to bind to. If someone gets infected with COVID, then there's usually about 5 to 7 day latency period. That means that if I actually am exposed to the virus and got infected on today, on Saturday, then I would probably start developing symptoms somewhere between Thursday and Saturday of this coming week. If could potentially have an infection later, or sorry, symptoms later or earlier though, because there's this really wide latency period before people start to demonstrate symptoms. And that range can go all the way from 2 days up to 14 days. That's why when you see the quarantine recommendations, if someone has been exposed to the virus, so a significant exposure, the recommendation is that you quarantine, and you actually quarantine for 2 weeks. That's because it can take up to 14 days to be able to demonstrate symptoms. Now, it's probably also worth noting that if someone is in that latency period, they aren't necessarily shedding virus, and therefore a test for the virus won't be positive, which means that you can't test your way out of quarantine. If I was exposed to the virus today and I got infected and someone tested me for the virus on Monday, I might still be negative and not show any positive test, but still come down with the virus 2 days later, or a day later, or 6 days later. So that concept of latency period actually is a big part of what determines our public health statements and recommendations with COVID-19. I think a second thing you got to remember is that viral shedding begins potentially 2 days before symptoms appear. So it's estimated that up to half of the disease transmission, at least in the United States, is occurring before people actually develop any symptoms. So that's shedding that in transmission that's coming from pre-symptomatic people as well as those who will never develop symptoms. And so that's why we can't just wait until people have symptoms to make the recommendations of social distancing, wearing masks, and things like that. Initially, the symptoms tend to be pretty mild. For most people, the symptoms will remain mild. It's estimated that 80% of folks will have mild symptoms if they get infected or have no symptoms at all. Some patients seem to have an increase in symptoms in the second week of the illness, and that does correlate with an increased likelihood of requiring medical intervention. But again, the vast majority of people, when they get infected, they're going to have mild symptoms, but they can still shed the virus. Typical symptoms that we would see are fever and cough and difficulty breathing. 90% of adults with COVID will have at least one of those first 3 symptoms. Folks can also have fatigue and muscle aches, headaches. The inability to smell or taste is something that's somewhat unique compared to, for example, fever. Lots and lots and lots of things can cause fever. A loss of taste or smell is something that there's a shorter list of diseases that cause that. And so if somebody has a new onset loss of taste or smell, then that would be something that would be certainly concerning for a COVID infection. It's also worth remembering that, again, up to 40% of patients are asymptomatic and won't develop symptoms during the course of their illness. We also know that there's some folks who don't do as well with the virus. Even though 80% of people who get symptoms are going to have mild symptoms, 20% are going to have more symptoms. Those risk factors for more complications from the virus include things like older age. I've seen an estimate that up to half of the total number of deaths have been related to folks over the age of 85. So we see that older age is definitely a risk factor for complications. Having had or currently having cancer, emphysema specifically, even more so than some other things like cystic fibrosis, but lung disease in general can be a problem. Folks who are immunocompromised almost always do more poorly with infectious diseases than others. Heart disease. The obvious ones are things like uncontrolled heart failure, but even hypertension seems to be correlated with an increased risk of complications. Diabetes is another one. And basically, it boils down to, I think, that about any chronic significant medical condition probably increases the risk of having complications with COVID-19 if somebody is infected. It doesn't necessarily increase your risk of getting an infection, but it will increase your risk of having complications. One of the questions I get quite frequently, at least about 3 times a week, is can I get reinfected if I've already been infected once? And the answer is yes. This is data that, again, science in real time, we're still trying to sort this out, but there's clearly been examples of folks who have had one infection with a strain of virus, and then a few months later, they get a second strain of COVID-19 and they get reinfected. So we can tell that it's not an infection that's just hung on for 4 months. It's actually a new infection. Now, I think it's also worth noting, though, that these are probably outliers. So of the, at this point, I think 30 million people that we've proven have had COVID-19 infection in the world, we only have a handful that have actually, we have good documentation of reinfection at 4 or 5 months post initial infection. So everything in biology, of course, is on a bell curve. And so these folks who are getting reinfected early are probably people who are off to the left of the bell curve. And that means that somewhere there's an average duration of immunity that would be in the middle of the bell curve. And we don't know what that is yet. We think that, or my guess would be that this is probably going to be somewhere around 7 to 12 months after an initial infection that people would be at risk of being reinfected. But again, we don't have good data because the virus just hasn't been around long enough for us to be able to show that. So how's the virus spread? Well, as everybody probably already knows, there's a lot of ways the virus can spread, but primarily we think about large droplets as being the primary way that it gets from one person to another. Now, there is growing body of evidence that aerosols, which are really small droplets, can cause spread. And there's at least still some risk of oral contamination. So that's if somebody coughs and touches a doorknob, and then I touch the doorknob and then I stick my thumb in my mouth without washing my hands, then that also could cause me to have infection. But as time goes along, it appears that the large droplets and the aerosols are probably more of an issue than the oral contamination. So wiping down your cereal box with Lysol probably is going to be unnecessary. If we look at what happens when somebody coughs or sneezes, there's different size particles that emerge from that. We have these really large secretions. So if you cough or sneeze into a handkerchief and you take a look at it and there's something green and gooey there, if you can see it, those are really big secretions. Those tend to come primarily from the upper airway. So that would be the nose, the potentially the posterior oral pharynx, and even the large bronchi in the lung. Well, those large secretions are pretty heavy and they're going to fall to the ground pretty quickly. Matter of fact, they're going to hit the ground within seconds. And these are things that are kind of large enough that they're visible to the naked eye. They're more likely to be generated by a cough or a sneeze rather than just talking. And they tend to have a lot of virus in them. But again, because they fall to the ground so quickly, we don't think that they're a big part of the transmission. We also have what we call large droplets. In this picture of a sneeze here, the large droplets might be kind of these cloud of stuff that you see coming out. And those large droplets are usually 10 to 500 microns in diameter. There's kind of a medium amount of virus that's in those. They will fall to the ground. Gravity still acts on them. But when they fall to the ground, they usually do it within about 6 feet or so. Now, this is not a sharp drop off that they fall to 6 or go to 6 feet and then just immediately plummet. It's again something that happens on a continuum. So in Europe and in many other countries, as a matter of fact, the WHO talks about trying to keep 1 meter or 3 feet distance between away from folks to prevent spread. And that's a reasonable recommendation. In the US, we do 6 feet is the CDC recommendation. That's actually based primarily on older influenza data. But the thought is still that the further you are away from somebody, the less likely you are to be able to pick up one of these large droplets. These can actually be generated, though, by talking, maybe by breathing, certainly by singing or heavy breathing. And again, we think that large droplets are the primary vehicle of transmission. We also see that we can get small droplets, and in this case, the small droplets here are basically just black spots. That's a scam call on my phone, sorry. But these small droplets, as they float around, I assume that's a scam. These small droplets, as they float around, they actually are things that can stick around in the air for a larger period of time. Because they are smaller, they can actually float around for even a few hours and may travel up to 24 feet. Now, the good news is these small droplets don't tend to have very much virus in them. But because they can be generated even by things like talking and breathing, we do think that they contribute to disease transmission. So just to kind of review here, we have a couple of just diagrams showing that if somebody is sneezing, and sneezing typically generates more material than what coughing does, about a fourfold greater amount. But even with breathing, which is our graph down at the bottom, we can get production of both aerosols as well as large droplets. And the distance, at least that the aerosol plume can travel, may be up to 24 feet, especially with something like a disease, or sorry, like a sneeze or a cough. So how do we prevent disease spread? Well, again, we got to think about how far the droplets and aerosols can travel. And we also have to think about what the actual number of virus or the amount of virus it is that it requires or that's able to cause infection. Theoretically, a single virus can cause infection. But the reality is that most of what we inhale gets stuck in the mucus in the lung, is broken up by the innate immune system, and actually doesn't cause infection. We don't know what the true inoculum size is, so the average amount needed to be infected from COVID-19, but it's got to be, the average is going to be something more than one. And there's at least some data that if you're infected with a smaller inoculum size, even if you go ahead and get infected, that you'll actually have milder disease than if you got a lot of infection or a lot of virus that you're exposed to. So it's kind of like if you drop a brick on your toe, it's going to hurt. If you drop a ton of bricks on your toe, it's going to hurt a lot. And so this was actually a nice little study done in Europe, where the 3 different clusters of outbreaks, those that are in green actually had were in a situation where their inoculum size was actually pretty small, and they actually had folks that would either turn positive and be asymptomatic or potentially had mild disease. Those who are in red and in blue tended to have more exposure, and those in the red with the most exposure. And you see that that higher initial exposure amount, that higher inoculum, actually resulted in more severe disease. So decreasing the inoculum size can actually be helpful even if you go ahead and get infected, which is why you're seeing more things in the news about ventilation. So the greater the amount of air exchange, the more the virus gets diluted and the lower the risk of disease transmission, and possibly the lower the amount of, or the milder the disease. So in general, outside is going to be better than inside. What about masks? I think that around the world, there's not a lot of debate about masks. So those of who are tuning in from other places may not feel that this is a very useful 5 minutes, but in the US, there's been a lot of debate about masks. And like with everything, the science is incomplete. However, we're going to go with the preponderance of evidence, which would suggest that there's 2 reasons to wear a mask. First of all, to protect those around you, and second of all, to protect yourself. Far and away, we think that the most efficient use of a mask is to protect those around you. So if I actually do a little bit of tuberculosis work for the state of Texas, and if I have a tuberculosis patient and I only have 1 mask, I'm going to put that mask on the tuberculosis patient and I'm going to go without, because I'm going to better protect myself by making sure that the TB patient has a mask that is close up around them. And the reason for that is that when we first cough, breathe, sneeze, anything like that, When the virus or when the secretions first leave the mouth, they tend to be at their largest size and tend to be the most likely to be able to get stuck, if you will, in the mask. So what we see is that almost anything that you put over the mouth and the nose of the infected person will decrease the risk of infection to others. There was a nice little study where they actually, this was done in Scotland, I believe, just recently, a week or two ago, where they basically had this apparatus set up that they would create droplets, they would push it towards a fabric sample, and they would see how well different fabrics worked. And the idea was that you have these droplets, these especially large droplets, they hit the fabric, and some of them are actually able to make it through the fabric, but for the most part, the fabrics would filter out the majority of the droplets. So in this case, they actually tested about 10 or so different types of fabrics. On the far left, you see is a surgical mask, and these are all compared to how many droplets get through if you don't have anything. So these are all compared to basically being unmasked. And what they saw was that anything that you put over your face is going to do something to prevent disease spread to others. Now, I think it's worth noting that fabric number 2 is actually just a t-shirt. And so this is not necessarily high-tech stuff. This is a low-tech, just something over the mouth and the nose, and that actually is going to decrease your risk of being able to spread disease to others. So you can be kind of creative with that, and Halloween is coming up, so have a ball. It also is worth noting, though, that it doesn't reduce the risk to 0. So just because I have a mask on does not mean I can't spread disease to others. We think there may be about an 80% reduction in disease transmission risk if the infected individual is actually wearing the mask. Now, bearing in mind, asymptomatic folks can be infected. Therefore, we don't have the option of just waiting until somebody develops a cough and a fever to put a mask on them. So if we know that masks are going to be able to prevent disease spread to others, well, what about yourself? So again, there's the thought that 2 layers of anything would probably help. And it's clear that surgical masks or the N95 masks, or if you're in Europe, we call them FFP1, 2s, or 3s, so that those higher quality commercial grade masks are going to do better than a cloth mask to protect yourself. But again, we think that almost anything will do something. So this is actually a little study. It was kind of fun. Back in February, I went out to my garage and built a little combustion chamber in my garage and bought a package of cigarettes and actually made the cigarette smoke. I didn't smoke them, I don't smoke, but made the cigarette smoke go through a filter made up of different types of fabric, and then we collected it at the back end of the filter to see how much particulate matter actually made it through. At the bottom, you see that there's no filter. At the top is a surgical mask. In between is just basically 2 layers of a simple cotton fabric, and you can see that almost anything does something to be able to keep that particulate matter that's floating through the air from getting into or getting onto the fabric. Now, it's not a real scientific study. My wife made me stop because everything I wore after that smelled like cigarette smoke. But what we think is, based off of better data than what I had generated, is that maybe a cloth mask, if I'm wearing a cloth mask and I'm interacting with someone who's infected, then I'm going to be able to decrease my risk by about 50% of getting disease if I'm wearing a cloth mask. So not quite as good as putting the mask on the person who's shedding virus, but certainly better than nothing. Now, if both the infected person and the susceptible person are wearing a mask, then that probably decreases our transmission risk down to about 1.5%. And that's based off of some data that would suggest that with a typical exposure, defined as basically interactions within 6 feet of each other that are unmasked for 15 minutes or more, has about a 1 in 5 risk of disease transmission if one person is shedding virus. Obviously, there's lots of caveats there. But if both parties are wearing a mask, then you drop that risk from 1 in 5 to about 1 in 75 or so, or about 1.5%. So significant reduction if everybody wears a mask. What about large droplets? Okay, so physical distancing. So again, large droplets may travel up to 6 feet. So I can actually avoid large droplets just by standing 7 or 8 feet away. I'll have more exposure if I'm standing at 2 feet than I am at 4 feet. Because again, it's not like these droplets travel 6 feet and then just fall off of a ledge. Aerosols, on the other hand, may travel further. So again, in general, the further away we are, the better. So as a mantra, in addition to good hand washing, I think it's worth thinking about that outside is better than inside, masked is better than unmasked, distant is better than close, and 2 out of 3 ain't bad. So if you're wearing a mask and you're outside, I'm betting you're in pretty good shape. If you're wearing a mask and you're 6 feet away, you're probably in pretty good shape. But we're really trying to get 2 out of 3 there to significantly reduce our disease risk. So how do we make a diagnosis of COVID? Well, unfortunately, there's not any really clear-cut symptoms that we can use to make a COVID diagnosis. There's no symptoms that completely rule it out or rule it in. Lots of things cause fever, lots of things cause shortness of breath. But certainly the inability, sudden onset of an inability to smell is suggestive of COVID, but not everybody has that particular symptom. So we're really dependent on these lab tests. And over the past 7 months, everybody's heard so much about the different tests. We're going to briefly run through the differences. First of all, the PCR test is the gold standard. This is the one that takes a small sample and it actually amplifies the nucleic acid, the genetic material of the coronavirus, until the point that it's detectable. We think this is the most sensitive test, and this is the one that came out first. Rapid antigen tests are ones that look at different viral particles and can come back a lot faster, but unfortunately they don't amplify anything about the virus. So if there's a poor sample, then it's not a very good test. And finally, an antibody test, we don't actually use for diagnosis of current infection. It may take up to a few weeks for an antibody test to turn positive. So if someone offers to test and see if you currently have COVID, and they offer to do it by doing an antibody test, go ahead and turn them down, because that's not going to be helpful for making a current diagnosis. So PCR tests, again, these can be done either on nasal swabs or saliva. There's some really interesting work that's being done on fecal samples as far as population monitoring. There's a lot of different ways that we can use PCR, and we've been using PCR since the 90s for so many different types of medical uses that we've got a really good track record with this. For COVID, we don't really know what the sensitivity is because we don't have a great gold standard, but we think maybe 85% sensitive. It's got a low false positive rate, meaning that if it turns positive, you truly are infected, with the caveat that people can still shed virus for up to 2 to 3 months after they have an infection, but the virus may not actually be a live virus. So it may just be virus particles, and the reason is that that sort of debris from the battlefield inside the nose can take up to 3 months before it washes away. So the cell turnover time in the nasal epithelium is up to 3 months. So we have had, and early on, we had a lot of issues with people would test positive, we'd recheck them 3 weeks, 4 weeks, 6 weeks later, and they were still having occasional positive tests. But when we actually try to get that virus to grow in a cell culture, we can't get it to grow. So we think that after about 10 days or so for mild disease, after people are infected, after their symptoms start, we think that most folks are actually going to be negative after about 10 days, and they're not going to be a risk of shedding virus. And if you were to test them at 30 days and they turn positive, that would likely be a false positive. It may take days to get these results back, though. It's really dependent on what your local resources are. So we actually locally here, we ended up kind of having to develop a workaround to be able to do more PCR testing locally instead of sending it out. It can be kind of expensive. The price tag varies a lot, but it is the gold standard. On the other hand, a rapid antigen test is a really only a nasal swab right now is all that we have good data for. It doesn't have quite as good a sensitivity, but you can get your results back potentially in minutes, and it's not very expensive. However, because the rapid antigen doesn't do any amplification of the virus, you're totally dependent on how good of a sample it is that you took. So I actually did a little video of swabbing myself. Somewhere I've got a mock-up that the NIH sent me one time as being a certified master swabber because of a study that we did. So I'm just going to show you how I do a swab, because I've had multiple patients that will tell me that, yeah, they got swabbed to see if they have COVID, and they basically took the swab and they sort of rummaged around in the top of the nose, and that was it. And unfortunately, my video, I don't know what happened. I'm a Luddite, but my video wouldn't go this morning, so I'm actually going to demo this live. So if I make myself throw up, please excuse me. Hopefully you can see this, because I'm only going to do it once, and I'll try to kind of talk you through a little bit. I've got a swab here. It's about, probably 7 inches or so, and we're going to go in till about this much of it is in my nose. All right, here goes. Go back. Ugh. All right, at this point, the swab is actually touching the very back part of my nasopharynx. I inserted the swab parallel to the roof of the mouth, but through the nose. So it's there, we let it set for a moment, we turn it, we pull it out a little till it's in the nasal turbinates, we turn it again, and then finally, we pull it the rest of the way out. And then we do it on the other side. So that's a good swab. If you got a good swab, then the tests tend to work pretty well. If the swab that your clinician does just sort of wiggles it around in the front of the nose, that's not a good swab, and it doesn't tell you anything about whether you actually have COVID. All right, well, what about vaccines? And I realize, I'm going to wipe my eyes here. If you're being swabbed and it doesn't make your eyes water or come out with a piece of pituitary tissue, then it's probably not a good swab. All right, what about vaccines? There is an amazing amount of science that has been put together in a short period of time on vaccines. And we are in a fast-forward race to develop a vaccine, and it's truly remarkable how quickly the science has moved. The effectiveness of the vaccine, when it comes out, is really going to depend on those phase 3 studies that, at least in the US, on those that are going to be marketed in the US, are still ongoing. Now, there have been in both Russia as well as in China, there's been approval for some vaccines that have not yet or completed what we'd consider to be a traditional phase 3 trial. But at least in the US and in Europe as well, we're really going to be dependent on those phase 3 trials to be able to know how effective a vaccine is. The guess would be that it's going to be between 50 and 80% effective. That means that if I get the vaccine, then I'm going to have somewhere between a 50 to 80% reduction in my risk of getting COVID if I was exposed. You may say, well, that's awful. If we're going to do a vaccine, I want it to be 100%, but we actually don't have any vaccines that are 100%. There's nothing in biology that's a guarantee. And so our typical flu vaccine usually has about a 55% efficacy. So if we get a 50, 60, 70% effectiveness on the coronavirus vaccine, that's actually going to be pretty reasonable. But it's going to depend on what the vaccine is that's going through. There's probably going to be multiple vaccines that come on the market in a short period of time. And even though all of these current candidate vaccines require 2 injections, you can't cross over from one vaccine to another. So for example, if I got my first vaccine from the Moderna vaccine, I can't use the Novavax vaccine as a booster because they're going to have a different mechanism of action and may have a little bit different target. So you have to use, the way we understand it now, you'd have to use the same vaccine for both the initial vaccine and the booster vaccine. And the timing even between those will depend on the vaccine as well. Some of them will be a 21-day before you do the booster. Some are going to be 4 weeks or 28 days for the booster. When are vaccines going to be available? I have no idea. I don't have any insight into that. I think that it's certainly possible that we could have an initial approval based off of phase 3 studies by late November or even December here in the US. But we're still looking, once we have availability, we still have to, once we have approval, we still have to have a significant increase in availability by ramping up production and getting that distributed all across the country. And in our little community of 250,000 here in Amarillo, one of our discussions at the health department is, all right, how do we give 500,000 vaccines? Because remember, we got to give 2 doses. And how do we do that over a 2-month period to be able to inoculate the population at large? That probably isn't going to be happening until, I would say, late spring, early summer of 2021. So we're still in this for a while. And then, of course, at least in the United States, one of the big questions is, well, are the vaccines going to be safe? And I think the answer is yes. Based off what our standard processes are for being able to evaluate phase 3 studies, these are going to be safe vaccines. And even though it feels like that the so many things with the pandemic, again, at least in the US, have become politicized, when the vaccine goes through its usual and customary processes, we're going to end up with a safe vaccine. Now, does that mean that it's not going to have side effects? No. Anything that we do has the potential for side effects. And there might very well be that somebody has an allergic reaction or that there's a very rare side effect that could occur. But I think the vaccine is going to be equally safe with other vaccines that are approved once it finally is approved. All right, what about COVID-19 and specifically periodic paralysis? Well, turns out we just don't have any data. I couldn't find anything that was specific to periodic paralysis related to COVID-19. We do have some data that may be relevant, especially to those who are potassium sensitive. So we know that an interesting little study that was done by Chen, and this is actually, I think, cited on the PPA website, but about 50% of patients that were hospitalized, at least, this was a study done in China, I believe, had a decrease in their potassium levels that were significant decreases, so that those potassium levels were below the normal value. That's actually not too surprising, both from the standpoint of this involvement of ACE2, which actually has something to do with regulation of potassium, as well as the fact that any significant illness or infection has a tendency to ramp up the stress response. And the stress response, because of cortisol release, actually can also decrease the serum potassium level and increase potassium excretion. Now, if we looked at folks who don't have COVID-19, if we go back to some of our old studies, we actually see that 40% of people who are admitted to the hospital for any reason will have a low potassium level at some point during their hospitalization. So the rate in COVID-19, a little higher than what the average is for non-COVID admissions, and is definitely something we need to keep a watch on. But it doesn't necessarily tell us that everybody who has periodic paralysis and has a COVID-19 infection is going to have a really low potassium. It's also worth noting that remdesivir, you remember we've got 2 medications that can act, that have actually, we've got pretty good data. The preponderance of data would suggest that they are helpful, and we've got randomized controlled trials. One of those is remdesivir, and that actually shows about 1 out of 20 patients who take remdesivir will get a drop in their potassium. That was as compared to, I want to say it was 1 out of 50 in their placebo control group. Dexamethasone, we see that certainly dexamethasone, just like any other steroid can and probably will cause some decrease in potassium. Dexamethasone and remdesivir both are actually only approved for folks who have severe illness. There is actually a recent study that came out last week, I think, on remdesivir. There was an open label study looking at moderate illness, but both remdesivir and dexamethasone are primarily being used for those who have been hospitalized. For example, dexamethasone, it's folks that are hospitalized and require oxygen, that we can actually decrease the risk of mortality by using dexamethasone. And if someone with periodic paralysis was hospitalized and required the dex, then I would certainly suggest go ahead and continue to do it. You're just going to have to keep a close watch on the potassium if you are hypokalemic PP. All right, a little bit of speculation here, because again, I've got no data that's specific to PP that I'm aware of, and I would certainly welcome if other people have better data. My observations on the handful of folks with PP that I know who've gotten COVID-19 is that they may have relatively mild disease, or they may feel like they got run over by a bus, which is very similar to those who don't have PP. They may have mild disease, or they may feel like they got ran over by a bus. So I think that the disease course in patients with periodic paralysis is likely, if they get COVID, to be similar to the disease course that they would have with other types of infections. Influenza can cause significant issues in periodic paralysis. Certainly having anything that causes sepsis from a bacterial standpoint can be a significant problem. And so I think that our patients and friends who have periodic paralysis need to be cautious, and I think should be taking care of themselves. But I don't see any data that the periodic paralysis itself directly increases the risk of having poor outcome or death if someone were to get COVID-19. Now, one question that's arisen is, do you empirically change your medication regimen if you're diagnosed with COVID? And I think that's a great question. I don't know that I would recommend that if someone has mild symptoms and that they have, with those mild symptoms, they get tested, they're test positive, I wouldn't necessarily change anything in their medication regimen at that point. On the other hand, if someone found that they were having to significantly increase their fast PP, should they increase a little bit some of their maintenance medications? Well, that's certainly something worth talking with your doctor about. But I think as far as a blanket statement that you should increase your potassium intake or change your maintenance medicines because of a COVID infection, I think it's premature to say that that is a standard recommendation. So what can we do to stay healthy? I think first of all, we try to avoid unnecessary social contact. Now, this is difficult, right? Because our prior presenter was talking about how important it is that we take care of our caregivers, caring for the caregivers. How important it is that these human connections, and humans are social creatures, right? We depend on those social interactions. But I think in this situation, I think that if you have unnecessary social interactions that you can avoid, then I would avoid them. So especially things that are where you have large groups of people that are indoors, places that folks are unmasked, those might be things that you want to avoid. I think that we also, though, need to stay connected. I think there's a real risk of people being isolated. We see that those issues with mental health that happen with any chronic medical condition have been exacerbated by the isolation that comes of having a pandemic. And we've seen this across the board, really, with all chronic illnesses. So folks have to be able to find ways to stay connected, even though they may be avoiding some of that physical social contact. I think we need to stay active. We know that both staying active and staying connected to our support group are able to decrease our stress levels. We know that stress, because of its effect on the sympathetic nervous system and subsequent neuroimmune reflex effects, can affect the way the immune system works. So if you want to keep your immune system healthy, try to be able to manage stress, and that includes things like staying active, appropriate exercise, staying connected to your support group and to your loved ones. Likewise, getting enough sleep. Sleep deprivation actually is directly linked to changes in how the immune system functions. So making sure that we're not spending all of our time binge watching on Netflix during a quarantine. I think that good diet, obviously, of course, our PP patients and friends are, I think, oftentimes the best amongst all of us as far as being able to stick with a good diet. It's kind of, you just have had to learn how to do that. But I think keeping that good diet and making sure we have a healthy diet. I have not seen any compelling data on different supplements. There are lots and lots of things that have been promoted. I think that as a general rule, if you have a specific deficiency, if you have a vitamin D deficiency, it's worthwhile to take vitamin D. I think that likewise, if you had a zinc deficiency, I would suggest taking zinc. Otherwise, I just don't know that there's enough data to be able to say that people need to be taking this particular supplement or that supplement in order to specifically ramp up the immune system. There may be a point in the future where we have better data on that, but right now I just really don't think we have the data to make that kind of a statement. And with that, then I guess I would go ahead and time out, and I would love to be able to open this up to any questions that folks might have. I've specifically tried to stay away from a lot of the hardcore data on therapies because I think that therapy data is really something that is a moving target. I think that it's something that you need to be able to have a conversation with your physician if you were to be infected. And so I try to kind of focus on things that I thought would be helpful from the standpoint of taking home as a patient or as a community member who might be exposed to PP. But I would, with that, be happy to open this up to any questions. Linda, you're going to have to help me figure out how to, we talked about a chat room.
Yeah, how about if I just read you some of the questions that have come in, Dr. Bell?
That sounds great.
Okay. First question is, Dr. Bell, I have a 3-year-old trach nocturnally vented G-tube son with congenital myasthenia syndrome, hyper PP, and PMC. Episodes are controlled with Diamox and salbuterol. The question is it safe for him to attend preschool? His medical team is saying it's safe.
So I guess, so first of all, you know, and I say this to when I'm covering the hospital all the time, you know, ask your nurse if you have a question. If they don't know the answer, they'll come to us. And if I don't know the answer, I'll make something up and you won't ever know the difference. The other thing that I always say is work with your doctors and develop a good trusting therapeutic relationship with your doctors. I don't know in that particular situation with your son if that's safe or not, right? I've never met your son. I would say that when I have a patient who, for example, I have, I think currently 4 children that I see, not from PP standpoint, but for other reasons that are chronic vent patients. I would say that in those kids, I've recommended that they not attend school. And so when you have a chronic ventilatory state, whether that's due to lung damage, like if a child has lung disease of prematurity because they were born early, or and also have cerebral palsy, or whether it's because of a neuromuscular issue, either way, you tend not to have as much pulmonary reserve. And even though children in general have done much, much better with COVID-19 than what adults have, I still think that in the situation, if I was seeing, and I've had this conversation with patients of mine who have a vent and are trached, and I've recommended that they not attend school and they actually do online learning. That is really, really difficult. And I totally get that. And especially for like therapies that they may be getting at school, speech therapy and occupational therapy and physical therapy. We've been trying for months to do those things online. They are really hard to do online. But either online school, potentially having the therapist come to the house, potentially shifting to where you're using a private therapist instead of the school-based therapist during this time, homebound services, depending on the state. Homebound services will sometimes provide a therapist to come to the home, which is different than online schooling. But I do think that if a child is a chronic vent-dependent child, they have less pulmonary reserve. And even though in general, kids do much, much better, and I don't think that your child would be at any increased risk of MIS-C, which is the multi-system inflammatory syndrome associated with coronavirus, MIS-C. I don't think your child would be at increased risk of that. I do think that if we had something, just like if your child got the flu, that's going to be potentially an issue that because we don't have as much pulmonary reserve, and I would tend to lean on the side of probably not going to school if I was the physician. Talk with your doctor about it, see what they have to say. If they have a good feel for what the what your child's actual pulmonary function is, now they're too young to be able to do pulmonary function tests, but if they've done forced expiratory volume and they say, you know, he actually does great, this is really just an upper airway obstruction is the only reason that we have the trach, and it's the only reason that we do the nocturnal venting, maybe that's a different story. But without knowing some of those details, I think I'd be a little bit cautious.
Thanks, Dr. Bell. This question is going to go back to actually one of your previous presentations. And Michael would like to know if there are any updates on links between hypermobility and dysautonomia and PP. Yeah,
great question. So the short answer is no, at least not from my standpoint. I haven't seen anything new in the literature. We actually had 3 studies that we'd kind of drawn out, one of which we'd gotten started, and of course we started enrolling in it in I want to say January, and this was basically just trying to develop kind of some normative data to be able to take a look and compare different types of hypermobility and just really get a better idea of some baseline normative data. And as you might imagine, research starting in January kind of took a back seat by the middle of February. So I am not actually aware of any updates on that. Again, for those who were fortunate enough not to have suffered through my last presentation, the hypothesis is that that hypermobility, that excess ligament laxity and joint movement certainly seems to be associated with trouble regulating the autonomic nervous system, and that when we look at periodic paralysis, then trouble regulating the autonomic nervous system could potentially explain common symptoms that we see in patients with periodic paralysis that don't make or aren't easily explained by the actual channel or the ion channelopathy. So issues, you know, if headaches are more common in periodic paralysis, well, that's not really a ion channelopathy thing. If dizziness was standing, that may not be as much of an ion channelopathy thing, but those would certainly be explained potentially by autonomic regulatory issues. And Michael, to my eternal chagrin, I have not done anything useful in, it feels like now, more than half a year. We hope to get those studies kind of up and going again. And as a matter of fact, we actually had to change. We ended up having to close our radiology suite because our radiology tech was a high risk person, and so we've now negotiated where we're using a little different radiology suite, and I've trained their folks on how to do some of this, the imaging, but I don't have anything new for you, and I'm very, very sorry. Okay, I have one last question for you, Dr. Bell.
Lois, a good friend of mine, says that she has a serious muscular reactions to flu vaccines and no longer takes these, but she's wanting protection from COVID-19. And she's wondering whether or not she should get the vaccine or not. Do you have any advice for her on this?
Yeah. So, Lois, great question. There is a lot of difference in how the vaccines, in how most of the vaccines are being produced compared to the way that we make the flu vaccine. That being said, I'm reminded I have currently one of my residents who is used to have a job back right after he graduated from high school, and he was an undergrad, and he had this part-time job where he was a roller coaster tester, and he was telling me about it the other day. And what they would do is they would get on the roller coaster, and it was him and a couple of the roller coaster engineers, and they would get on the roller coaster, and it was the first time that the roller coaster was run with anything besides a test dummy on it. And they would go zooming over, and they would turn the speed up and down in order to make sure that the roller coaster worked. And that is incredibly frightening to me because I don't like roller coasters. I would suggest, I think, that although I certainly think that at some point there's going to be, I think there's going to be better data for you in particular. As someone who has always tolerated vaccines very easily and well, I plan on getting a vaccine as soon as one's available. If I was somebody, though, who had historically not done well with the vaccine, I might actually not be the one who volunteers to test the roller coaster. I think I would wait until the amusement park's been open for a while and lots of other people have gotten on the roller coaster and make sure that they tolerate it fine. And then I think I would climb on and pay my money and get the vaccine. I think that the other thing to bear in mind with the vaccine is that perhaps even more so than the individual protection that we would see coming with a vaccine, the community protection has probably even a greater impact. So if we were able to get 50% of the population of the U.S. to be, ideally, let's say that we got 75% of the population to take the vaccine, and that vaccine was 70% effective in being able to prevent both disease acquisition and virus transmission. Then over the course of a few months, because of that built-in protection and the effect then on the rate of spread in the community, what we would actually see is that the R value, that's the number of new people getting infected from one person who has an infection, would drop below 1, and we would see that the virus would start to die out. Not that we're ever going to entirely get rid of this virus. At this point, it is baked into our ecosystem. But it would get down to the point that our risk of getting disease would be significantly decreased compared to what it is without a vaccine. So, it's a personal decision, I think. I don't know for sure what to tell you, except that I probably wouldn't be the first one to sign up. I certainly also would not say I'm never going to get a vaccine because I did poorly with the flu vaccine. I think you're going to need to watch and wait and see, but bear in mind that there is a glimmer of hope in that we're going to see benefits to decrease disease transmission because of more immune people running around in the community, even if you personally don't end up getting a vaccine.
Well, thank you so much, Dr. Bell. It's been a pleasure as usual. You've entertained us and you've given us so much valuable information, so thank you.
Well, thank you, and I think I'm going to go blow my nose now.
Okay, thanks so much. So, everyone, next up, we have Strongbridge Biopharma give us a presentation. And I will be switching the control of the screen over to them in just a couple of minutes. But we're also going to be doing a 5-minute break. But first of all, I just wanted to say at this time that all of this that's happening today, we owe to Strongbridge Biopharma. They have been absolutely outstanding in being our premier sponsor for several years now in bringing you these conferences, and we're indebted to them greatly. So please enjoy their presentation with Dr. Silvestri, which will be coming up next. But right now, stand up, stretch, get something to eat if you can get it. And next person on the screen you're going to see is Strongbridge Biopharma. Thank you.
Hello, and welcome to the 2020 PPA Virtual Conference. My name is Benita Sharma, and I am the Executive Director of Patient Advocacy and Public Policy at Strongbridge Biopharma. Strongbridge is honored to, once again, be the premier sponsor of this year's conference. Even though we cannot be there with you physically in Chicago, we appreciate the chance to connect with you virtually. We would like to thank the Periodic Paralysis Association, their board, and their membership for this opportunity to present the You Are Not Alone, the Power of Advocacy, Education, and Support educational program. In these challenging times, we at Strongbridge wanted to take the opportunity to provide you an informative session that looks at primary periodic paralysis, or PPP, from 4 viewpoints: road to diagnosis, the impact of PPP, the management and treatment of PPP, and the support that Strongbridge can provide for those living with PPP. Today, you will hear from individuals who can speak to each of these areas from their own experiences and perspectives. Our goal was to incorporate both the physician expertise in diagnosing, managing, and treating PPP, and equally so, ensuring that the patient voice also was captured, incorporated, and resonated through each of the sections, as you are not alone in living with this condition. Dr. Nicholas Silvestri from the University of Buffalo, Department of Neurology, a physician who specializes in PPP, will begin the program. And throughout the 1-hour session, you will also get the chance to hear from some of our patient mentors and their personal experiences in living with PPP. Janine, John, Leslie, Paul, and Kim. In closing, you'll hear from my colleague, Matt, one of Strongbridge's patient access managers, who will discuss his role, Strongbridge Care Connection, our dedicated patient support service center, and the resources that Strongbridge can provide to patients and their family members. Whether you suspect the diagnosis, are newly diagnosed, or been diagnosed for quite some time, Strongbridge has resources and support for you and family members every step of the way. You are not alone. Before we begin, please know that any medical questions regarding the diagnosis and/or treatment of your primary periodic paralysis, or PPP, must be directed to your healthcare provider.
Hi, everyone. We're on a break until 2 p.m. when Dr. Cannon will be joining us. So feel free to get up, move around, do whatever you have to do. Thank you. Hi, everybody. As you can see, I have a friend with me. It's Dr. Cannon. You all recognize him. And I'd just like to read a short introduction, if I can get through all these big words. Dr. Cannon is an MD, PhD, and chair of the Physiology Brain Research Institute at UCLA. He is the professor in the Department of Physiology in the David Geffen School of Medicine at UCLA. He received both a BS and an MS in mechanical engineering at Washington University in St. Louis in 1980. His master's thesis explored how increased muscle stiffness and intensity of stretch reflex with mechanical loading produces an instability that may cause tremor. Upon graduation, he entered the medical scientist training program at Johns Hopkins, where he worked with Professor David Robinson to identify the locus of the brainstem neural integrator for the ocular system and demonstrated how lateral inhibition is a critical neural network feature of his premotor circuit. He completed a medical internship and neurology residency at Massachusetts Hospital, where he was chief resident in 1990. Dr. Cannon then completed a research postdoctoral fellowship in David Corey's lab, where he made a fundamental discovery of the sodium channel defect that causes susceptibility to periodic paralysis. Based on this new work on channelopathies of muscle, he started a lab in the neurology department at Harvard Medical School, where he was on the faculty until 2002, when he moved to the University of Texas Southwestern Medical Center in Dallas as chair of neurology. In 2010, he became associate dean for undergraduate medical education and developed a combined BA-MD training program with the University of Texas in Dallas. In 2015, Dr. Cannon was recruited to UCLA as the chair of physiology at the David Geffen School of Medicine. So welcome, Dr. Cannon. We're happy to see you again, and I'm going to turn it over to you.
Thank you so much, Linda. I think the audio is registering, and I'm just waiting for the screen to pop up.
Yep.
Which is coming, and I have 3 monitors active, so I'm not sure which screen you're seeing. Sorry, are you able to see my slides? I'm not sure.
Yeah, no, not yet. I see connected, go to webinar. See, yeah, you are the presenter. It's not this.
Let me try to swap which screen is showing. How about that?
There you go. That's good.
Okay.
I'll see you in a little bit.
Okay, fine. So first of all, I'd like to thank Linda for the kind invitation. I think this is now my 7th time of attending the PPA meeting, and I always learn a lot from every session. I've learned far more from coming and meeting you all and speaking with you than any textbook I've read or seminar I've attended. So I really appreciate your willingness to share your experiences. And I've been following along all morning, even with the challenges of COVID. This meeting has been running very well this year, and despite COVID and the fires in California and the fact that we had a magnitude 4.5 earthquake last night in Los Angeles, we're all still here, so that's fantastic. So as you can see on the title of my slide, I'd like to provide for you a review of some of the genetics and research updates in periodic paralysis. You've had a wonderful introduction from several speakers this morning. And I always like to start off by making sure everybody's on the same page. And whoops, that was not the right page I wanted to be on. Sorry, I think this just changed to a funny view for everybody. Let me move this over. Trying to get this controller off your screen. Pretty much unobstructed screen, I hope, for you now. So first of all, to remind everyone that in periodic paralysis, the problem resides in the muscle itself. So this is a view through a microscope of a mammalian muscle fiber, a single fiber that's been teased out in a dissection. So in a large muscle like your bicep, you would have tens of thousands of these fibers. Each one has a very special connection to the nervous system from a single motor neuron that makes a very special contact, which is how the information comes from the brain and the central nervous system to tell your muscles when to contract. And so in periodic paralysis, the problem is not with this nerve and how it's able to communicate information, or the special connection between the nerve and the muscle, the neuromuscular junction, but rather it's the problem in propagating the message from this connection to spread throughout the length of the fiber. Because muscle fibers are very, very large in comparison to this little point of contact. And so it's essential that this signal be spread rapidly and with high fidelity throughout the entire body of the muscle so that contraction is uniform and very consistent. If we take a cutaway view here of a cartoon, this is the nerve coming in. I just want to make you aware that not only does this signal need to travel along the outer surface of the fiber, but also propagate deep into the center of the fiber, which is where the machinery resides for converting this electrical signal into releasing calcium from these special stores shown in this blue here, because calcium released inside the fiber is the chemical signal to enable the initiation of contraction. So in periodic paralysis, the problem is in this communication where the electrical signal would travel over the surface of the fiber and down into the depths to enable the release of calcium and initiate contraction. So I want to also just make sure everyone's on the same page. We've heard a lot of wonderful introductions today about the types of symptoms individuals with channelopathies of skeletal muscle can experience. And we've also heard that it's all about the individual and there can be great variability, which is essential in optimizing patient management. But I want to review for you the core features so that we can focus on, from a research perspective, what we've been trying to understand and what successes and achievements we've made in there and how that applies to optimizing management for individuals. So as you've heard, one of the manifestations of an ion channel disorder of skeletal muscle can be this persistent involuntary after contraction that fluctuates depending on the level of activity. Most individuals refer to this as being stiff after a voluntary movement. That neurologists refer to as myotonia. Many of you recognize that the symptoms are often most severe with the first few movements after having been at rest for a while, and that it may resolve in a course of 30 seconds or a few minutes with modest level of repeated activity. This is the so-called warm-up phenomenon that happens in many forms of myotonia. Dr. Jerath mentioned earlier this morning that some variants have this paradoxical response where with repeated muscular effort, the stiffness actually becomes worse. This kind is often sensitive to temperature, aggravated by cold, and this paradoxical worsening is the basis for the name paramyotonia. And oftentimes, in addition to going outside, in which it affects muscles that are out in the periphery of your body, so in the hands or in the face on a cold winter's day, that drinking chilled beverages will cause stiffness of the tongue and slurred speech to happen under those circumstances. So in myotonia, you have an abnormal excitability of the muscle fiber. So with the needle electromyogram, the physician can document in the outpatient setting the fact that all of this excessive self-sustained bursts of action potentials are occurring in the muscle. In addition to you feeling stiffness, at times it's possible for the physician to demonstrate myotonia by tapping not on a tendon for a normal stretch reflex, but to tap right on the belly of the muscle. And here you see this persistent dimpling, which should not normally be there and is a sign of this abnormal after activity that occurs in myotonia. So in the context of disorders of electrical excitability, this is obviously an enhanced excitability because the muscle continues to discharge autonomously when in fact it should have stopped and resolved. Periodic paralysis, which is the main focus of our talk this morning and of the association, is the exact opposite. So here, an individual will have recurrent, it's key that they come repeatedly, episodes of weakness. They typically have a gradual onset. We've heard some of the accounts today in the Strongbridge presentation that some people have rather abrupt onset, but in general, most of them evolve over minutes to even the course of a day. And in some individuals, the episodes are most commonly experienced with first awakening in the morning. The duration can be quite variable. As we've heard from Dr. Jerath this morning, that can be a challenge to physicians unfamiliar with this condition to try to understand what the basis might be, because some individuals experience episodes that only last a few minutes, while others stretch into hours or even a day or more. It's also very clear that individuals cannot quite return to 100% strength for weeks at a time. So there can be very protracted episodes. The severity is also highly variable. It can be from relatively mild, where there's a self-perception, but others might not appreciate it, to complete immobility with loss of muscle tone. And we've heard from many this morning that a characteristic feature that's really helpful in the diagnosis in defining periodic paralysis is the fact that there are environmental factors that can bring on an attack or act as a trigger. So resting after a prolonged period of strenuous exercise is one of the most consistent triggers. We've heard in some individuals there can be changes in diet, so high carbohydrate content or salt content for people with hypokalemic periodic paralysis, or too much potassium in the diet for hyperkalemic periodic paralysis can trigger an event. Emotional stress as well as physical can be a common trigger factor, as well as alcohol ingestion. As you've heard, for the individual, it's very important to be mindful of triggers, to keep an accurate diary, because in working with your caregivers, this can be one of the most important strategies for minimizing the frequency and severity of episodes. It's also a very active episode of the research in our animal models of periodic paralysis, because if we could understand the trigger factors more completely, that would be a huge advantage to help individuals minimize the effect on quality of life from the frequency and severity of attacks. I will touch at several points in my talk on the issue of the slowly progressive permanent weakness. Clearly, this weighs very heavily on minds of people with periodic paralysis. It's what some people are understandably most concerned about. And as you'll hear through the talk, it's an area where we're really struggling to understand the basis of why this happens and be able to accurately predict for whom this is going to be an issue. So let's think about episodes of weakness in periodic paralysis, and I want to bring some clarity to you all of what is wrong with my muscle during one of these attacks. Clearly, it's a functional change. something that's happening on the time frame of seconds to minutes. And as I mentioned, in every form of periodic paralysis, whether it's hyperkalemic, hypokalemic, Anderson-to-Will syndrome, even periodic paralysis associated with thyroid disease, in every single case, there's a common mechanism. So let me remind you in cartoon form here, in the normal situation, this red trace is showing this electrical signal, which is a change in the membrane potential, that is the voltage across the muscle cell. So normally in a quiescent resting muscle, there's no change over time. And when it's time to contract, there's this brief electrical transient we call an action potential. And this is the initiating trigger, which causes the calcium release, and then an increase in force or tension in the muscle that follows very quickly thereafter. So for a patient with periodic paralysis who's in the asymptomatic period, which, as you all know, is most of the time, they have normal resting electrical activity. So I'm showing it in a unit called millivolts. These are thousandths of a volt. So normally, for all of us, when you are at rest and relaxed, in loose terms, the battery to tell your muscle when to contract is charged. It's charged at about minus 100 millivolts and sitting there resting, waiting to go. In an appropriate stimulus, here in this computer simulation, which is injection of a small amount of current, that tells the system it's time to go, and there's its all or none fast change in the voltage, which is the signal for the muscle to contract. What's happening in every individual with periodic paralysis is when you're experiencing weakness, your battery, in essence, is partially run down. That means the voltage is closer to zero. What happens is, although becoming more positive in a brief event is what triggers contraction, if you partially go there and get stuck, the system becomes resistant to responding. It's so-called refractory, so that even when the appropriate stimulus comes, here in this artificial simulation or from an input from a nerve, your muscle will not respond with the normal amplitude and very clear signal that it's time to go. And so there's a failure of this electrical signaling, and that is the essence of what's going on during periodic paralysis. So all of the research is to understand why these variants or mutations in ion channel genes cause a partial rundown of your battery, why that happens only intermittently, why that's associated with characteristic triggers, and what we can do about it. So how do we relate these various ion channels to the clinical symptoms? So as Dr. Jerath mentioned in her talk this morning, there's a lot of overlap in the clinical symptoms and presentation in patients with channelopathies of skeletal muscle. There are two cardinal features, being either myotonia, which is this involuntary after contraction and stiffness, or periodic paralysis, which is transient episodes of weakness from which there is recovery. And these two entities have been recognized by physicians for over 100 years. In working with patients, clinicians have identified different categories, so-called different syndromes, where some individuals have myotonia from birth, but they do not have periodic paralysis, hence the name myotonia congenita or congenital myotonia. Other individuals have periodic paralysis in which in the 1940s it was recognized those episodes are associated with either an increase in the blood potassium or a decrease in blood potassium. There's been a lot of focus on potassium levels in association with periodic paralysis. It's been very helpful to make a diagnosis and, importantly, to distinguish between these two categories of disease, because the management is completely different for these two forms of periodic paralysis, so it has very practical importance. There are other forms, as you've heard, where paralysis can come with paradoxical worsening of myotonia. And I've put a circle around these two conditions because in my view and many other neuromuscular specialists who focus on periodic paralysis and channelopathies, there's extensive overlap between the clinical features of paramyotonia congenita, hyperkalemic periodic paralysis, and normokalemic periodic paralysis. And I would really put those in the same category. And we've all seen families where different members in the same family who have exactly the same genetic basis for these symptoms can look like the features more characteristic of paramyotonia congenita or more characteristic of hyper-PP. So that can happen in the same family. And this is why I would lump those together. Hypokalemic periodic paralysis has the distinguishing feature that the blood potassium is low during the events. And importantly, it's extremely rare, I won't say never, but extremely rare for an individual with hypokalemic periodic paralysis to have myotonia. And that can be a helpful distinguishing feature for making an accurate diagnosis. And if it's a little bit ambiguous in terms of what the patient is able to report or the doctor can see on a physical exam, this is where the needle electromyogram can be very helpful to look for laboratory electrical evidence of myotonia. The Anderson-Tawil syndrome, as you've heard, is a variant of periodic paralysis that also involves cardiac rhythm disturbances, as well as changes in the formation of bones and body structure. And there's another form of periodic paralysis associated with thyroid disease. But in every one of these variations of periodic paralysis, we now have established that the common, well, these are all rare diseases, but most frequently, the underlying defect is in one of these little molecular machines, a so-called ion channel, that's responsible for regulating the flow of sodium, potassium, chloride, or calcium in and out of the muscle fiber. And as you can see, the different clinically distinguished entities are associated with problems of different ion channels. So chloride channels for congenital myotonia. Sodium channels, is very interesting, can cause a wide variety of different clinical phenotypes. And this is an area that our laboratory has been working on for this year, makes 30 years we've been studying these, whereas the calcium channel mutations have all been for hypo-P, et cetera. You also should be aware that in the genome of humans and animals that there is not just one type of sodium channel or one potassium channel, but there are many, many different variants. So each of those variants is encoded by a separate gene. For example, in humans, there are 10 different sodium channel genes. It's been shown that 9 of those form functional channels. And the special one called the NAV1.4 gene is expressed in skeletal muscle, for example. This is very relevant because this particular type of sodium channel, the one that is mutated in periodic paralysis, is only expressed at significant levels in skeletal muscle. So it is not present to significant levels in other electrically excitable tissues like nerve, brain, or heart. So that's why typically individuals with defects in these channels do not experience arrhythmia or seizures or peripheral neuropathy. This is the name that researchers give to the particular channel, which, apology for all of this jargon and nomenclature, but it's a different naming system for the gene. So these abbreviations down below are what you see in the report back from genetic testing. So it's the SCN4A gene for the sodium channel that's expressed in skeletal muscle. Or the calcium channel gene, so that's calcium channel type 1S for the calcium channel and hypokalemic periodic paralysis. Now, interestingly, what makes sense scientifically is there's one exception here, which is that these particular variations of potassium channel genes, they are so-called inward rectifier genes, that's what the IR means. These are expressed in considerable levels in the heart and in bone, as well as skeletal muscle. So this is why the arrhythmia and anomalies in bony features and so height, shape of fingers and face and things like that can be affected in Anderson-de-Will syndrome as opposed to these other channelopathies where skeletal muscle is selectively affected. So I'm going to now spend the rest of our time together telling you what we've learned about the basis for which these variations in these channels, because of these gene variations that you've inherited, why does that cause periodic paralysis? Because, you know, we strongly believe that understanding why is the first step in taking a rational approach to optimizing interventions to modify the burden of disease, help improve your quality of life, and maybe even someday be able to offer a cure. Now, I'm going to tell the story primarily in cartoon form. If there are any who are watching today that are really interested in some of the hardcore science behind this, 2 years ago, I gave a talk at an international channelopathy meeting in Chicago. Strongbridge was kind enough to have a professional recording of that, and it's available as a Vimeo online recording. Here's the URL for the website. And what's also some of you might find interesting in this presentation is I used that opportunity to really highlight the enormous contributions from Professor Frank Lehman-Horn, who many of you know came to many sessions of the Periodic Paralysis Association, and was really a pioneer in understanding periodic paralysis, but unfortunately passed away a few years ago. So let's get on with what's wrong with these channels. Why do I get episodes of weakness? Why is my battery susceptible to partial rundown? So I'm going to start with and focus a lot today on the sodium channel. So it turns out that for these variations of the clinical presentation of hyper-PP, paramyotonia congenita, as well as normal kalemic periodic paralysis, for these individuals who have sodium channel-based myotonia but no paralysis, for all of them, they share a common problem in the way the variants or mutations affect the behavior of the channel. So here in cartoon view, what I'm illustrating for you is that what a channel does is it helps these ions, these little dissolved salts. So for example, sodium, these little balls are to represent sodium ions in solution to move from outside the muscle fiber to inside. This orange line here represents the barrier between the inside of a muscle fiber and the outside. Biologists call this the membrane. I'll refer to it as the cell membrane. And so these channels literally form a conduit or a pore between the inside, between the outside and the inside. And in order for this delicately tuned system to work properly, it's essential not only for this access pathway to be formed to help the signaling occur in your muscle, but it has to be open and at the appropriate time. So there's conceptually a gate shown here that's occluding this pathway that might be open or closed. And it needs to be open only very briefly at the appropriate time to allow this electrical signaling to normally occur. So for all of these conditions, the problem is the mutation occurs in the part of the channel that's regulating the operation of this gate. And the gate is open inappropriately more than it should be. So it's a gain of function, more sodium comes in, and that's the basis for all of these channelopathies caused by sodium channel defects. Interestingly, for hypokalemic periodic paralysis, and what was a real challenge in the field for over a decade of having identified these mutations, is that the first mutations were identified in the calcium channel. Bernard Fontaine's group in Paris, working with Frank Lehman-Horn in Germany, mapped this to chromosome 1. Louis Patachek in Utah, and then San Francisco was the first to find a mutation. And then Mike Hanna's group in London has found many more. So it's been an international collaboration. Initially, it was thought there was this nice distinction. Hyperkalemic periodic paralysis was going to be a sodium channel disorder, and hypokalemic periodic paralysis was viewed to be as different because it's a calcium channel defect. Well, about 8 years into this story, it was discovered that many families who clearly had hypokalemic periodic paralysis did not have a calcium channel mutation. And Angelica Hahn in Canada had a large family with this scenario, and Dennis Bowman, who's a molecular geneticist, helped her look at these families and found that in fact they had a sodium channel mutation. And initially there was a lot of resistance. This is now about 1999, that many experts in the field thought, well, this was just some anomaly, a single family. This was not going to be the case. But it has now turned out that many investigators went back to the samples in their freezers for families who clearly had hypo-PP characteristics, but no calcium channel mutation, and they had sodium channel mutations. So now we know that about 60% of families where there's a clear history of inheritability with a hypo-PP phenotype will have a mutation in the calcium channel, and about 15 or 20% in the sodium channel, and there's still another 20% for whom we don't know. So this was very satisfying in terms of helping patients and understanding of the genetics of the disease, but it was a real mystery for physicians and scientists who study the way excitability is regulated in a muscle fiber, because sodium channels and calcium channels do very different things. They have different jobs that they perform in the muscle. The sodium channel is responsible for that brief electrical transient, the action potential that we talked about, whereas in skeletal muscle, the calcium channel is a sensor of a voltage change. It doesn't cause it to happen, it senses it and triggers when the calcium should be released. So for two types of channels with very different jobs, it was hard to understand how mutations in either one of these could cause the same clinical scenario, because there must be some overlap. And finally, the insight came in about 2007. Our lab and another lab discovered that in this situation, both channels, whether it's a sodium channel or a calcium channel, becomes leaky. So it's not a problem with the regulation of how sodium or calcium comes through the normal conducting pore, the normal channel that lets these ions come in and out of the cell and regulate excitability. But instead, there is a little sidebar here, another part of the channel complex shown with these little pluses here, because part of the channel is sensitive to the voltage across the cell. It's the so-called voltage sensor. And in hypo-PP, that's where the mutations reside. They're clustered there, which I'll show you in the next slide. But what it does is it causes a leak through the voltage sensor, not in the gates that are regulating the inflow and outflow of ions through the channel. So it was a completely different class of functional defect. It explains why this was a different category of clinical scenario with different symptoms, but it also explained why this could occur with either a sodium or a calcium channel, because this voltage sensing mechanism is conserved for both channels. It's evolutionarily conserved. And so the molecular defect in either one of these could cause a similar functional defect. So here's a different view. In the gray bar, here's our membrane again. This is a ribbon cartoon of the sodium channel. This is the calcium channel. You can see these cartoons look pretty similar, and that's to reflect the fact that in real life, there's a great deal of similarity in these proteins that are coded by two different genes. Each one of them has about 2,000 amino acids, and the genetic mutation is what's changing one individual amino acid. What I want to remind you of in this slide is that over the years, we've identified in this diagram here that there are certain parts, certain places along this string of amino acids where this part of the channel controls its voltage sensitivity for either one. And what I want to point out is that of the 11 mutations that have been identified in families with hypokalemic periodic paralysis in the sodium channel gene, all 11 of those occur in these voltage sensing domains at a particular type of amino acid that's the arginine. There are 20 different amino acids that can be encoded by a particular gene at one location. We use the abbreviation R, so they're all R's here, but look at this. All 11 of them are a missense mutation at an arginine. And in the calcium channel, 8 of the 9 described in the literature are also missense mutations at arginines, all in the voltage sensor. There's one exception. It's been proven it causes the same functional defect. These all cause the leaks. Okay, so why am I going into this minutia? It's because this can be very helpful in a genetic screen if you were looking for the basis of hypokalemic periodic paralysis. So while this will not explain the inheritance of every case of hypo-PP, it explains the overwhelming majority. And so you should, as a physician and molecular geneticist, you should expect to see a variant in either one of these genes that affects an arginine in the voltage sensor domain. If that's not the case, you really have to wonder whether this is a benign variant of unknown significance and not the basis of hypo-PP in this family. So this is an example where knowing a little bit of detail about the science that goes behind this can help in a very practical way of interpreting a genetic test. What I'd now like to do is explain to you why this unusual leak that's created by these mutations causes susceptibility to hypo-PP and how we can use that information to strategically design interventions. So there are many different approaches to this. What we have done is genetically engineer the mouse. So there are no natural, you saw a video this morning from Dr. Jerath of the infamous quarter horse, where that was a spontaneous mutation that causes hyperkalemic periodic paralysis. A wonderful opportunity to learn more about periodic paralysis, but it's a little cumbersome, as you could imagine, to have horses in the laboratory and raise them, although the University of Pennsylvania has done that in their veterinary school. And I've had the opportunity to actually see those horses. It's quite amazing. But a spontaneous mutation that causes hypo-PP has not arisen in mice. So we use genetic engineering to create the sodium channel mutant mouse. And as the advantage of this is we can study the mouse muscle under very controlled circumstances. So we remove the calf muscle of the hind limb of the mouse. It's in this little jar here in solution. A nice warm bathing solution. Here in pink, you can see the calf muscle of the mouse that we can now electrically stimulate and control the environment and measure the change in force that occurs in this mouse muscle. So here's a typical response. This is time and force. These are individual trials for mice that have a different genetic background. Just like humans, mice have 2 copies of every gene, including the sodium channel. So the plus indicates the normal mouse. So this is a normal mouse with 2 normal copies of the sodium channel. And if we apply a series of electrical pulses for about a half a second, there's a very rapid and robust increase in force in this mouse muscle. And if we challenge this mouse with, instead of being at about 4.7 milliequivalents of potassium in the bathing solution, which is what you have in your normal body, but decrease it to 2 millimolar, the normal mouse tolerates that pretty well. There's only a modest change in force. But if we take a sample from a mouse that has 1 mutant copy and 1 normal copy, so this would simulate what happens with patients who've inherited this mutation. Now, when we give the 2 millimolar potassium challenge, there's a clear and dramatic reduction in force. And what we're able to do in mice, which is one of the advantages of this laboratory model, is we can interbreed the carriers and have a so-called purebred mouse that has 2 copies of the channel mutation. These mice appear normal. They're able to feed and reproduce and run around the cage, but they're much more susceptible to hypo-PP. So in this mouse, if we expose it, here's the baseline force is less than normal in blue. And if we give it a 2 millimolar potassium challenge, you see the force drops all the way to essentially 0. And then if we return to normal 4.7 millimolar potassium, it recovers. So this shares all the features of susceptibility to low potassium induced attacks, and they are reversible. So this very clearly shows that it is indeed possible to have a single genetic variant in the sodium channel and have a hypo-PP variant, just like we've seen in patients. I want to show you similar results from our model of a calcium channel mouse. Instead of showing the raw force traces, I'll now talk about the maximal level of the force. So how much force relative to normal is able to be generated. So we've made a mutation of the R528H variation in our mouse. This is the most common cause of hypo-PP in humans. This particular missense mutation. And sorry, I didn't change the label on the mouse here. We've actually made the R528H in the calcium channel. And now what I'm showing you is similar to these results. We're showing the relative amplitude of the force, starting out being 100%. And we're doing this test of measuring the force every 2 minutes for an hour, for 60 minutes. And over the first 10 minutes, the force is very reproducible and very stable. And if we then challenge this muscle with 2 millimolar potassium, for the normal mice, there's a little bit of a decline, but the force is relatively well preserved. Whereas for these male mice in dark, there's a 60% loss of force. As long as the potassium is low, the force stays low for 30 minutes, and then when we return to normal potassium, here's the recovery. So again, showing a transient episode of weakness, all the characteristic features of hypo-PP. I want to point out to you that interestingly, in the female mice, in a 2 millimolar potassium challenge, they can become weak as well, a little bit more slowly for the mice that have a double copy of the mutation, but the mice with a single copy are more like the wild type. So this is not a low enough potassium challenge for them to have a trigger. And this occurs in human patients as well. As many of you know, in particular with the calcium channel mutation, the R528H, Tara Links has published on this in the 90s, large family in the Netherlands, multiple affected generations, where many women do not have episodic attacks of weakness, although unfortunately they can get the permanent progressive weakness. And so, you know, this is an opportunity to learn more about this gender specific basis for susceptibility to weakness, and really demonstrates the amazing high fidelity of these animal models. I want to stress to you that we recognize mice are not humans, that these are approximations of human disease, but there are a lot of mouse models of disease, of cancer, of neurogenetic diseases, of autoimmune diseases. But these channelopathies of periodic paralysis are some of the best high fidelity models of human disease that we have. And here's another example of reproducing those characteristics of the human disorder. So we took this muscle and challenged it not only with 2 millimolar potassium. So here we're changing the potassium, that we're challenging this mouse model. We do it outside the body in a dish, because of course in the body there are a lot of mechanisms where, just like in a human, the mouse's body is going to attempt to regulate the potassium level, and we can't as easily control it in an experimental manipulation. That's why we take the muscle out of the body and we can vary the potassium. And what I want to show you is this is essentially a dose response curve. So indeed, if we increase the potassium, there's no difference between the maximum level of force of these mutant mice and the wild type. The problem is in low potassium, and you can see a dose response curve. The lower the potassium gets, the worse the problem is. And it gives us some sense for when this muscle begins to be in trouble. You could never get this data from humans. You need to do this on a muscle fiber itself. You can't do this from a skin biopsy, growing fibroblasts, even doing fancy, induced pluripotential stem cell research. You just can't do this. You need whole muscle. Frank Lehman's Horns group did pioneering studies on patient biopsy material. We really appreciate the participation of those patients because you're talking about an open biopsy to have a large muscle sample. But that preparation is viable for about 12 hours. So only limited studies available on measuring force, which is an example why these mouse models have been so important to establish this information. So now what we've shown is we've reproduced the model. We have found out that it's leaky channels, but how do you connect the leak to the risk of being susceptible to a loss of force in response to potassium? And I'll show you the story gets even a little bit more involved because it's going to involve chloride as well. So I don't want to overwhelm people, but I just want to point out some of the important players that come into consideration of understanding why this leak puts you at risk of having your battery partially run down and have periodic paralysis in the setting of low potassium. So this cartoon of a cylinder represents the muscle fiber, and there are many different ion channels. Here I'm showing 2 different potassium channels and a chloride channel. There are pumps that use the metabolic energy of ATP by burning glucose to establish a concentration difference of the salts between the inside and the outside of the fiber, and other transporters that bring ions in and out. And all of these, in an orchestrated way, regulate the excitability of your muscle fiber. And by understanding how each of these players contribute, we can use computer simulation to ask, how well is your battery charged? What is the voltage across this muscle as a function of the external potassium? This is your blood potassium level, which normally is between 3.5 and 5. So normally you're in this range, and in the normal situation, the model cell says in this range of potassium, you go up to this black line, your battery would be pretty well charged, very well charged, and you're all set to go and would enjoy normal excitability and strength. What happens is as the potassium in the blood and outside the muscle fibers gets lower and lower, which can fluctuate for changes in diet and exercise, diarrhea, sweating, a lot of things can change the potassium level. It bounces around. For most of us, it's not a problem. In your body, it would be extraordinarily rare for potassium to get much below 2.5. You begin to have a lot of problems with rhythm disturbances of the heart and other electrically excitable tissues. But what I will say, and what helped us understand it, is that even if you study normal muscle from patients without periodic paralysis or mice or other organisms, is that if the potassium becomes extraordinarily low, lower than could ever be achieved in the body and be compatible with life, but if you make it low enough, the battery partially runs down. So instead of the battery getting stronger and stronger and stronger and better charged, this paradoxical shift happens. And while that sounds like a laboratory esoteric curiosity, this was really the insight that helped us understand what happens in hypo-PP. Why does your battery run down in low potassium? Because if you take this scenario and now introduce the leaky channels that cause hypo-PP, so there's an inappropriate inflow of a little bit of sodium because of a mutation either in the sodium or the potassium channel, then the impact that that has on this computational stimulation of excitability of muscle is it shifts this relationship to your right. What that means is this transition as your potassium is getting lower and lower outside the muscle. The normal random variability here in the potassium level, now when you're down at the low normal level, there can be a problem where the battery partially runs down, your muscle fiber is now refractory, it's inexcitable. This will cause periodic paralysis. So it's this shift caused by this mild leak is why you have hypo-PP. So that's important because if we could modify the behavior of either the mutant channels or perhaps other contributors to electrically excitability of muscle, there's the chance we could shift this back and get you out of trouble and thereby improve the management of episodes of weakness in periodic paralysis. There's one final point I want to make this, and then we'll get back to reality a little bit and away from these theoretical diagrams. But I want to point out the variation in potassium and the symptoms you experience. Now, it is, again, a very important feature of these diseases that the susceptibility and the risk of having an episode of hypo-PP is dependent upon the potassium. And when potassium gets lower, you increase the risk of an episode of weakness. But it's important to realize, and as shown in this diagram, that if you're in a lowish level of potassium, like around 3.2, so you go up a vertical line here, my potassium is 3.2, and I have a mutation, so the dotted curve is the relevant analysis here. You could be sitting here, which is well-charged, good membrane potential, and you will be asymptomatic. But with this very same lowish potassium level, you could be up here with your battery sufficiently run down and symptomatic and inexcitable. The point is, it's not just the potassium level, it's also what state you are. And that's why, as you've all observed, there's a biologic complexity of interpreting your potassium level and am I going to be weak or not? Because some people with hypo-PP, this curve for the individual could be stretched over this way even further. Some people with relatively normal potassium can have an intermittent attack, and I'll show you that in the mouse model. On the other hand, if potassium is low enough, sure, everyone will get an attack. But there are these interesting overlap regions where you might or might not have an attack. And we know that clinically from what patients tell us. We see that computationally in the model. It's right here in the fold in this diagram. And we see it in the mouse models. So that's a really robust part of this condition. And you need to be aware of that because you should not overinterpret a particular potassium level. It's valuable and in keeping your diary to know what's my level and where do I get in trouble, but don't overinterpret it. And physicians need to be aware of this because if they see a patient in the emergency room, there can be a difference in time between when the attack occurred, whether the person took potassium, where they are in the recovery, and can it be really difficult to use the potassium level in establishing a diagnosis. And this illustrates some of the complexities there. So what we'd like to know is when is an individual going to be on this part of the curve and be asymptomatic and have normal strength, and when are you going to be up here? And again, I don't want to be overly detailed about this, but we've learned that the amount of chloride you have inside your muscle is effectively the switch that biases the system to whether you're going to be down here and asymptomatic or up here. And if the chloride content in the muscle is low, you'll be in a favorable situation. And if it's high, that'll be unfavorable. So I want to be clear that there are many mechanisms, this channel and this co-transporter, that in very sophisticated ways regulate how much chloride is inside the muscle compared to outside. It's much, much lower inside than outside. We'll talk about some medications and things you can do to bias that balance and improve your opportunity for being asymptomatic. But please don't misunderstand this and think by varying the chloride in your diet or what you consume that you can affect this balance. There are other ways we need to approach that. So in theory, the idea was if we could keep the chloride low inside the muscle, you would avoid this and things should be better. The main mechanism by which chloride becomes elevated inside muscle and other cells in the body is this transporter. This so-called sodium-potassium 2-chloride transporter is in every cell of the body, and it responds to changes in the number of things that are dissolved in the cell, whether you're hydrated or dehydrated. I'll get to that in a moment. But this transporter is very strongly inhibited by this potent diuretic called bumetanide or Bumex. So the hypothesis in just understanding the science behind periodic paralysis was that if you could inhibit this transporter with this drug, that might be beneficial for hypokalemic periodic paralysis. So we tested that in our animal model. So here's the sodium channel mutant model of hypo-PP. We're studying the muscle in the dish from this animal. Here I'm showing the raw data, the electrical stimulation for half a second. Here's the normal maximal development of force in normal potassium. We take this same muscle and lower the potassium to 2 millimolar, which for a patient with hypo-PP would certainly get you in trouble. And the force is lower in this animal model. Even staying in 2 millimolar potassium, but now adding 1 millimolar of bumetanide on top of that, there's a dramatic recovery of increase in force. So here's a rescue of weakness within a few minutes by applying a realistic level of bumetanide that you could achieve in the body. We performed this study on the calcium channel model of hypo-PP as well. Again, this is the most common inherited form of periodic paralysis. The control amount of force. If you challenge with low potassium, here's the attack of reduced force. You stay in low potassium and add bumetanide. There was a partial recovery, in most cases not complete. Just to show that the muscle is still healthy, if you go back to normal potassium, there's recovery. I will say that if you do this in a preventive manner, so administer the potassium, the bumetanide before the potassium channel, you can be completely protected. So there was a lot of enthusiasm for this as an opportunity for management of periodic paralysis. I apologize. I'm going to, I know I'm 55 minutes into the talk, and I'm going to look for messages from the organizer. Linda was kind enough to put my talk in the end. She knows I tend to go long. I have some more content I'd like to have. I'm not going to shortchange the questions, but I want to make a few other important points about this hypo-PP story and this transporter. First, I'd like to
feel free, Dr. Cannon.
Okay, thank you. And just pop in. I'll say that in trying to manipulate the multiple monitors I have on my computer, I cannot live see the comments from the moderators, so please just break in with audio and I'll adjust. So another really exciting area just in the last 2 years that we've been able to explore with these mouse models is the connection between exercise and episodes of weakness. Because while this is clearly recognized by patients and physicians as one of the most consistent triggers, we had only guesses. There was no clear understanding of how to connect those dots. And so it was hard for us to develop strategies to help protect people before they wanted to exercise and again, improve lifestyle. So this actually started back with Frank Lehman Horn studies on biopsy samples from humans in the 1970s and 80s, as well as some insights on the way that acetazolamide and dichlorphenamide might be benefiting. And it focuses on the fact that under conditions of really vigorous and extreme exercise, in part of the metabolic process of burning fuel, burning glucose and things like that by your muscles, a byproduct is acid. And the muscles themselves and your blood develops higher levels of acid during exercise. A curious thing about the weakness in periodic paralysis is it comes after exercise, not during exercise. So while we all recognize that exercise, if you will, is the trigger, the curious thing from a mechanism is that somehow exercise is protecting you. And so Professor Lehman Horn in the 70s and 80s tested this with human muscle fiber strips in the lab and showed that in hypo-PP, if you lower the potassium and the muscle becomes weak, in the laboratory, if you increase the acid in that bath, you can cause that muscle to recover. So he had this insight. So we followed it up 30 years later when we have the genetic model of the mouse. And so what we're showing here is, again, our experiment of the mouse outside, the muscle outside the mouse body. We're monitoring the peak force, measuring the force every 2 minutes. This is an 1.5 hour experiment. Every dot is a separate measurement. And what we varied, we didn't actually exercise this muscle with repeated contractions, but in the bath, we changed the amount of acid. So you may remember from your high school chemistry and biology, pH refers to the amount of acid. Lower pH means more acidic. So what we did is for 30 minutes, we made this bathing solution more acidic for either a normal mouse muscle or our 2 models of hypo-PP or our model for hyper-PP. All the different variations of muscle fiber tolerate this acidosis just fine. You see the muscle force stayed relatively preserved. But when we quickly went back to a normal pH, so this is what would happen after exercise when you rest and the acidosis recovers. What happened in the 2 models for hypo-PP is there was a dramatic decrease in muscle force. It didn't happen for normal muscle, did not happen for hyper-PP. Now, I will acknowledge patients with hyper-PP have exercise-associated weakness. So a different mechanism is happening. Something else is going on. We need to do more science. But for hypo-PP, what was curious is regardless of whether it's a calcium channel mutation or a sodium channel mutation, both of which give leaky channels, you're at risk of this, so-called after exercise loss of force. And I will tell you from studying hundreds of muscle fibers in the laboratory from our mouse models, this recovery from acidosis is a much more consistent trigger for a loss of force in our mouse models than the potassium challenge. And potassium has that fuzziness to it, and I think many patients, and you all who are listening out there, drop me an email and let me know, because I learned from you. Patients tell me that really the exercise phenomenon is one of their most consistent triggers, even more so than potassium. So I'd be interested in knowing about that, because that's what we see in our animal models. So what we'd like to know is the same mechanism we saw for the low potassium challenge. We showed you that blocking this transporter with bumetanide was very effective for the low potassium triggered loss of force. What about these so-called exercise-induced loss of force? So we looked at it 2 different ways. Sorry, I got ahead of myself. One is how quickly you recover from exercise. So you all have told me, so I took my lead from your story, that if after exercise, if you recline on the couch And we heard this from some stories about patients this morning, but that's a high risk behavior to trigger an attack. But if you slow down and warm down your exercise, or if you start to feel the onset of an attack, you resume exercising, you can abort an ongoing attack. So we tried to confirm that phenomenon in our animal model by not having an abrupt recovery of the acid-base balance, but a very slow recovery. And that's what I'm showing here. So these lines are actually measuring the amount of acid in the bathing solution. So in both cases, for our hypo-PP muscle, we make it more acidic. This is the exercise period. In one muscle, this was from one leg, we rapidly correct the acid, and in the other leg, the same animal, we slowly correct the acid. And look at the difference. The rapid correction is a much greater susceptibility to loss in force than slow. So again, the fidelity of these animal models for helping us in the laboratory to in detail investigate what you have told us and help us understand why this difference is beneficial. What I will say is that immediately this tells me that the stories that you relate to us have strong mechanistic scientific basis, and I really put a lot of credibility into that warm down or re-exercising, and you should be aware of that. Your doctors who take the time to listen to you have been making this advice for years, and I would just encourage everyone to do it because we can see it's a very robust phenomenon. So go back in sequence. We also tested bumetanide for the exercise situation. This is my abbreviation for bumetanide. So if you don't administer bumetanide, this simulated exercise causes a dramatic loss of force. But in the paired muscle from the other leg, if you pre-treat with bumetanide, you can completely prevent the loss of force. So not only potassium-induced triggers, but also bumetanide. There's another interesting consideration that relates to the video that was shared in the Strongbridge vignette. You heard about someone for whom dehydration is a trigger for their attacks. And that's the first time I heard that story, actually, but you all have told us that if you eat a lot of potato chips or pretzels or have a high, not potassium salt, but sodium salt ingestion, that can increase your risk of having an episode of hypo-PP. And that's very interesting because this co-transporter here, its normal job is to regulate the balance of salt between the inside and the outside of cells, because if you have a lot of dissolved salt, so-called hypertonic situation, or if you're dehydrated, that'll cause your cells to shrink, or in the other direction, to swell. And to regulate and compensate for shrinking and swelling, that's the main job of this transporter that we're inhibiting with this drug. But there's another way to modulate this, because that is to regulate its level of activity. If you're well hydrated, drink a lot, don't eat a lot of potato chips, that will naturally decrease the activity of this transporter. So that's similar to taking this drug. So the prediction is, if you stay well hydrated, you'll slow down this activity, you'll have less chloride inside your muscle, that could be beneficial. Conversely, if you're dehydrated because you haven't been keeping up with fluid loss, or you eat a lot of potato chips, that's going to cause this transporter to be very active. It's going to bring chloride into the muscle, and you could increase your risk of having an attack. So we studied that in the dish. So we can just control the amount of so-called hydration or dehydration. And what's new, we published some of this earlier last year, but in what's unpublished is that we can change the amount of hydration, which is what your physicians call osmolality. It's something they can measure in your blood. It's normally has a value of about 290 or 310. And in our paper, we had huge changes in the amount of hydration because scientifically, we just wanted to explore a proof of principle. But we've gone back and revisited that, looking at more modest changes in the amount of hydration. So what we've done is our mock exercise experiment in a hypo-PP muscle. Here's the normal amount of force. We have simulated exercise in normal level of hydration. That's a risk for triggering a loss of force. If we take the paired muscle from the other leg of the same animal, but before the simulated exercise, we just dilute the bath solution a little bit by 7%. The muscle tolerates that just fine. That dilution doesn't cause any change in force. But now the recovery after exercise is completely protected. So reasonable amount of hydrations, of hydrating yourself, has a real scientifically verified opportunity to improve protection from having an exercise-induced attack. Conversely, if we induce simulated dehydration, this is a change of from 290 to 310 for the physicians in the audience, a modest change in dehydration and increased osmolality. Even before the simulated exercise, the muscle that experiences this begins to have a loss of force. So dehydration is bad. Interestingly, when you induce the acidosis, the muscle recovers a little bit. This is the phenomenon of something that goes on during exercise is protective. You don't get an attack during exercise. This is probably also how carbonic anhydrase inhibitors are working, because they cause your blood to become a little bit more acidic, and that's protective. But now when the simulated exercise is abruptly corrected, without protection, of course, you have an attack of weakness. But in the dehydrated case, it's even greater loss of weakness and even prolonged period of time. So again, very robust, consistent evidence that dehydration is clearly bad, hydration is better for you. The other thing I'll point out, and then I think I hear Linda coming on the audio, is that all of these phenomena you're seeing, a dramatic loss of force in a model of hypo-PP, was all induced when the potassium was normal at 4.7. So I want to remind you that it's a combination of features and susceptibilities that comes into play with whether or not the excitability is going to be compromised and the muscle is going to become weak. So the level of potassium is one thing, but the balance of the chloride in the muscle and hydration is another. So we have to be open-minded about considering multiple factors that come into play for regulating excitability. So these were some word slides that I'll put out here, which just it's reiterating what I've already said about what we've discovered in the laboratory, how that helps with diagnostics, how that helps with recommendations for lifestyle, and what that implies for symptomatic management. And the slides will be on the website, and you can see that. Linda, I have about 5 minutes without data, but to talk a little bit about future in diagnostics and gene therapy for periodic paralysis. I can take 5 minutes, or we can switch to questions, whichever.
Go for it. Go for it.
Okay. So I'd like to, in the last couple of minutes, be forward-looking for the future horizons on advances in periodic paralysis. So to show you how recent this is, this paper was published just about a month ago. And this was a collaborative study on a lot of individuals who are studying the bioinformatics of inherited diseases, many types. There was a focus on diseases caused by mutations of ion channels, but not just for periodic paralysis, also for epilepsy and for arrhythmias of the heart. The epilepsy situation has been particularly challenging because there are hundreds of mutations that have been identified, way more than could be studied individually in the laboratory. And so you need some overriding principles in bioinformatics to begin to make sense of this. So we face this same challenge in periodic paralysis. I will say that in the sodium channel story, if you combine hypo and hyperkalemic periodic paralysis, to my list and the publicly available lists, there are now maybe 70 or 80 mutations that we're pretty confident cause susceptibility to periodic paralysis. For the calcium channel, there are fewer, more on the number of about 15 published and another 5 that are on the verge of being published. But any of you who've gotten laboratory results back from Invitae or Fullerton Labs or others, these are high quality laboratories. The accuracy of looking for changes in the genetic code is robust. It's not detecting the change, it's interpreting the change that's challenging. And so you get back this dreaded report VUS, which stands for Variant of Unknown Significance, because the science is still at a place where, although we are sure there's a variation in your genetic code, we don't know what the impact of that change is yet on the way that channel will function and whether that actually increases your risk of periodic paralysis. So what this paper did was, again, a bioinformatics, sophisticated machine learning approach at cataloging all the genetic tests that have been done, all of the science that's been done in studying those channels and trying to put this together. And what I'll show you is one example. So here's our friend that I showed you before, which is a cartoon of the sodium channel. The calcium channel would look very similar. What these investigators are sharing with you, here's the membrane separating the outside from the inside. And like all channels, this protein, what the gene is coding for, with 2,000 amino acids, folds in and out of the membrane. That's how it forms the ion conducting channel. What they've color coded here is from all of this literature, what location on the channel have there been variants associated with pathologic changes that affected the way the channel behaves and caused symptoms in patients versus variants that did not either change the way the channel behaved or consistently show symptoms in patients. And so this kind of mapping is going to help us and help Invitae. They use very sophisticated algorithms. I've spoken with them. I'm very impressed with the service they provide. But this is going to be another tool to help interpret this genetics and hopefully reduce the number of variants of unknown significance. So I just wanted to make you aware that there's additional developments there. Invitae is on board with this. All of these entities are consulting the scientists who study these channels, and so there's reason to be optimistic that the interpretation is going to improve. So that's great. In terms of therapeutics, you saw in my examples before working in the mice, we're really getting a better resolution at being able to provide you recommendations for lifestyle changes and drugs that can modulate susceptibility. And I'll tell you, there's more exciting stuff on the way that we're working on, hopefully in the not too distant future. But I really want to get to this question because it came in to some of them advanced questions that came in to this year's webinar and meeting. What about this slowly progressive weakness, permanent weakness? It weighs heavily on everyone's mind. We've heard about the impact it can be on mobility. It's vitally important, and it's frustrating because the amount of information that's available is much less. Even today, the precise mechanism is not well understood, not for lack of trying. Lots of work has been done both on human biopsies, looking at trying to understand how channels affected, examining the pathology of these muscles, looking at metabolic changes. And we're still looking for it. I will say that in the mouse models, you know, people will say, you know, you've got the models, why won't you help us? Why won't you look at that? And the challenge is, so at any one time, we have about 400 mice in our laboratory with periodic paralysis. And we've had these mice for over 10 years. And in all that time, in all those mice, I've only seen about 2 or 3 mice that developed permanent weakness and were dragging their hind legs. And we studied those very carefully, but unfortunately it was unrevealing. So it's a very rare event in the animal models. So that's making it hard. The other thing is to have, we all know that one of the more consistent features of this in patients is the risk increases with advancing age. You don't have to necessarily be 50 or 60 years old. It can come earlier, and physicians need to be aware of that. But everybody recognizes the risk increases with age. Well, the equivalent of a 40 to 60-year-old human is about, you know, a 14 to 16 or 18-month mouse. And when you're trying to get funding and sponsor students and do studies on aging, that's a huge challenge in doing animal models of disease for aging. So there are very real challenges, and I just wanted to make you aware of them, and it's not for a lack of trying or a bias or undervaluing the importance of studying permanent weakness. I want to speak to what is out there because it's important for you to think about managing your symptoms and optimizing the way you deal with periodic paralysis to try to minimize the development of permanent weakness. Physicians who've seen lots of patients, more than myself, and have looked at this for years are convinced, we don't have double-blind trials because it would be unethical to do it, but trying to look at natural history and historical data, that it's not good for your muscle to have these recurrent repeated attacks, and that repeated severe episodes is not a good thing and is probably increasing your risk of permanent muscle weakness. On the other hand, it's very clear, and again, some of the best data comes from Tara Links and her colleagues in the Netherlands. Beautiful studies, multi-generational family with genetically documented R528H, for whom many, many individuals, especially women, developed significant proximal muscle weakness in advancing age, who never had a recognized attack of acute paralysis. So there's clearly a dissociation that occurs. So I would not say episodic attacks is a prerequisite, but it still makes sense to do the best you can to minimize the severity and frequency of attacks to decrease the likelihood of this happening. So, and again, we don't have an established animal model. And so really the opportunity for permanent weakness is looking more towards the cure. And again, I apologize for my time, but in the next 3 or 4 minutes, I want to tell you where we are on gene editing technologies. So here the idea would be to actually, in patients, engineer the change, the missense mutation that you have that's putting you at risk. Because this is like the home run swinging for the fences. Even if we don't understand the mechanism of putting you at risk for permanent muscle weakness, it makes logical sense that if we could correct the genetic defect, that should reduce the risk and hopefully stop the progression down the road to permanent muscle weakness. So let me remind you of where we are. And a lot of you have seen on the news for the past several years, this CRISPR-Cas, which is a molecular tool to edit DNA. It was discovered in bacteria. Actually, people studying cultures to make yogurt in France was actually a discovery. So put a plug there for basic science of genetic mechanisms. And the amazing thing is these enzymes that cut DNA in a very special way work in mammalian cells and can work in human cells. So the big player in this is the Cas, which is shown in gray here, which is a pair of molecular scissors that can cut DNA. So the whole technology here is to be able to cut your DNA to deal with a mutation and perhaps do some useful editing. Of course, you have to cut in a very precise, special place. And that's from this other piece, which is a little strip of genetic material. Instead of DNA, it's RNA. So it's not deoxynucleotide ribonucleic acid, but it's ribonucleotide acid, RNA, tongue twister. And it's this RNA that helps target the molecular scissors to tell where to cut. Now, it's easier to make cuts and destroy a little site on DNA than to make repairs. That is, in periodic paralysis, you are actually in a favorable situation for using that type of gene editing. Because as you've heard, many cases of periodic paralysis, the reason why it's genetically inherited, you only need one copy to become symptomatic, is because the mutant copy is a bad actor. So it's actively doing something deleterious. So if you could go in and disrupt the mutant copy, you'd get rid of the bad actor. That's part one. But part two is we already know from both human genetics and animal models is that you can get by perfectly well with one good copy. So it's the one bad player that's messing things up. If you reduce the number of copies to one, but that one copy is good, you will be fine. So this is well established in animal models. We actually deleted one copy of the sodium channel gene in mice, and they're fine, and they do not have periodic paralysis. And the group in London, the University College London, Francesco Mutoni, working with Mike Hanna and his group, studying a different disease, congenital myopathy, stumbled across recessive mutations in the sodium channel and showed that in patients, if you're missing one copy, you're going to do okay. You're at risk for a mild congenital myasthenic myopathy syndrome, but you're not going to have periodic paralysis. So that's robust evidence that we could, in theory, cut and disrupt the one bad copy and potentially correct hypo-PP or hyper-PP. The challenge is you don't want to also snip the bad copy, and they differ by only one. And the specificity of where you're making the cut is this alignment. Each of these lines is aligning matching nucleotide pairs. And this probe is only about 20 nucleotides long. So it's a 1 in 20 difference that we have to develop high specificity. And that's where a lot of the work is. A newer development that's in the past couple of years is through protein engineering, is they took these special scissors and they destroyed the cutting capabilities of this Cas enzyme, and they fused it to another molecular trick, which can edit the nucleotide that will be coded for this, a so-called deaminase can change a G to an A. So now we have not molecular scissors, but editors. So this is really exciting because you would not destroy the mutant copy and be left with only one normal copy, but you would correct the mutant copy and then have two good copies. So these are both strategies that are under active investigation for many human disorders that are completely applicable to periodic paralysis. So while these molecular tools are available, and we're already studying this in the dish, as I'm sure lots of other labs are, I want you to be aware of why we are a long way from just giving you an injection and doing gene editing and helping you. One I've already mentioned is it's absolutely essential, the specificity of where these scissors are acting or where these editing activities are occurring. And that's all about the specificity of this guide RNA probe. And it's going to require a lot of convincing controls in model systems before we're able to apply that. in humans, and this applies to any gene therapy for any human disease. The other challenge is, how do you deliver this to the cells? So gene therapy is happening in some cases where in some cancers that affect blood cells in the bone marrow, because you can take out the patient's cells, do the gene therapy in the dish, and give them back. You can't do that yet for the satellite cells that are the stem cells for skeletal muscle. So there are many groups working on delivery systems to bring gene therapy tools to muscle. So for example, not just in periodic paralysis, but a lot of the muscular dystrophies like Duchenne muscular dystrophy, et cetera. And people are using innovative technologies of using adeno-associated viral vectors to shuttle it in there, or nanotechnology to encapsulate the particles that will be engulfed by muscle. So this is very active. So I want you to be aware that, that these are ongoing, that the horizon is bright. I'm sure this will happen, but there's a lot of work that needs to be done. But this work that is happening is directed to periodic paralysis as well as other inherited diseases. So I'll just end. This is truly my last slide, and then we can either take a gap or go to questions, whichever you want to do. As is traditional in science, I want to thank the sponsors. The National Institutes of Health has funded our lab for 30 years, especially NIAMS, National Institutes for Arthritis, Musculoskeletal, and Skin Diseases. And the Muscular Dystrophy Association has been a real challenge. You've heard it many times. Getting funding to study rare diseases is a challenge. All these sponsors want to help as many people as they can, and it's just a tough choice of where to direct the resources, and we're grateful for everything that comes to us, and I'll promise we'll do everything we can to help you. And these are the names of some of the individuals that you can see on the papers. And now I think I'll let Linda now ask the questions. Some of you that came in have more slides, not to overwhelm you. If the discussion does go to the ryanodine receptor that was brought up this morning, I just have two visuals that I think will help clarify if we want to go there in the discussion, but let Linda open it up to the questions. And thank you for your patience in letting me run over.
All I can say is, wow, Dr. Cannon, it's been amazing. I'd like to ask Dr. Jerath to also put herself back on camera if she would. There she is. And put her on, there you are. We have so many questions that I know, Dr. Cannon, I did give you some preliminary questions. I don't know if you want to look at any of those, or whether you would rather that I ask you some that have come in since you've been talking, since they pertain to your presentation.
So I can do either. So we are now sharing the cameras and not the slides. Is that correct? Fine, you can stay there.
Yeah, I'm looking. Yeah, I've also got the cameras up on my screen, so okay. I can't share my screen and your screen at the same time.
Okay. That's fine. I will. This first slide is about the permanent muscle weakness, and it's from Deborah, and that it happens even without episodic attacks. We went into that, and that really the opportunity is gene therapy. So we touched on that. Another question, and this came up at the meeting in Scottsdale a couple of years ago, that many of you have heard about stem cell therapies or platelet-rich plasma or bone marrow aspirates for helping in many disorders where we're struggling for therapeutic options. And while I'm, want to be open-minded about everything, as we heard back then from the experts, these therapies are certainly not going to replace muscle cells. So if you're in the status of permanent muscle weakness and loss of muscle replacement by fat, this approach is not going to replace your muscle cells. Do not be confused about that. There are other disorders in which these therapies have worked when some of the challenge is inflammation, especially autoimmunity conditions. And while I want to be open-minded again, there is no evidence that inflammation has anything to do with periodic paralysis. So from first scientific principles, I have no enthusiasm for platelet-rich plasma, bone marrow transplants, or stem cell therapies right now with where the technology is for periodic paralysis. And I just want to save you aggravation and a lot of money that I don't think that's an opportunity. And I'll let Dr. Jerath speak because I'm sure you face this in your practice.
I 100% agree with you, Dr. Cannon, on your stance on that. So none of those treatments make any sense scientifically. So.
Well, Dr. Jerath, I actually have a question that someone specifically asked me to ask you, but maybe Dr. Cannon can chime in too. They wanted to know, they said, Dr. Jerath, when you come back on again, perhaps we could do an informal poll about how many people meet the established diagnostic criteria. We could ask the following and have people virtually raise their hands to get an account. How many of you in the audience have a suspected or confirmed diagnosis of periodic paralysis? Please hit the hand button on the right-hand side of the screen to raise your hand if you do. And they go on, but they were wondering, just because we have so many people together with us right now, is there a way that we could do anything like that?
You know, I'm new to this whole conference association, so that's something that I would probably want to discuss maybe offline with Dr. Cannon and with other leaders in the field. I think there's probably quite a few out there that have their opinions. That's something that I think for other diseases such as, you know, ALS and other neuromuscular conditions, they've had committees come together to form diagnostic criteria, and it takes many minds to get those questions answered and those diagnostic criteria streamlined so everyone's in agreement. So that may be something that we need to do nationally and internationally. And had that as a scientific committee, maybe we need to establish something like that. And for patients that are borderline, it's hard because you know what we're learning is that there are genes that we don't know about and what they do. So those are hard cases, but I think that we should still come together and establish some newer diagnostic criteria. That's my suspicion. From all the patients I've encountered all over the country. I don't know what you think about that, Dr. Cannon, if you have any thoughts.
Yeah, so I would agree, and you've raised the really important point that there's a spectrum of sort of level of confidence of any diagnosis in medicine. And very true for periodic paralysis. And I want to make, you've made this point, but I want to make sure all the patients explicitly and viewers out there that physicians, we often focus on has there been genetic confirmation and so forth. And that's not to make any kind of judgment about the level of enthusiasm or attention to helping you, but it's really important that as we sift through the differences of people and what helps and what hasn't helped, that we don't mix apples and oranges, and that we be as accurate as we can in forming uniform groups and systematically understanding natural history and what helps. And so that's why there tends to be the focus on, you know, is there a genetic basis? And I've had the good fortune to be able to speak with some of the leaders around the world who've done the genetic screening. Our lab has never done that. We do the functional studies. And my understanding is that with very well clinically documented cases, and in addition to all the points that Dr. Jerath mentioned about at the bedside and the history, which is of course where to start, but with Bertrand Fontaine's contribution from Paris, this CMAP exercise test and Dr. McManus before him is really terrific because it's an objective clinical neurophysiology test that really is convincing for physicians that there is underlying periodic paralysis. And in some of those cases, maybe up to 20%, we just cannot find the genetic basis still. So everybody needs to be open-minded that there is bona fide organic periodic paralysis without a genetic understanding. It's there, and we need to respond accordingly.
Yeah, I absolutely agree. And I think that I have quite a few patients with variants of uncertain significance. And then some of them have gone to your lab and have also discovered more variants. And so I think maybe we can always collaborate to help these patients, because it's hard to make sense of variants. You have to do a lot of groundwork to make sure that they're actually disease causing. You have to, confirm them scientifically. And so there is that genetic component, but there's also the clinical component. And sometimes it's hard when patients don't have the genetic confirmation. So I sometimes rely on that clinical component. And I think at some point, with that normal bulimic periodic paralysis concept that a lot of physicians don't really understand, I think that we may want to develop guidelines for that at some point as a scientific community.
Yeah, I'm so glad you brought that up, because people who are not physicians who are not familiar with periodic paralysis, they have the opportunity to draw a blood sample while someone is symptomatic. If the potassium is normal, they think they've excluded the diagnosis, and that is a huge mistake. Huge mistake. So.
Let's see. I have one here from Sarah, and she says that we've been told that pain is not associated with any of the PPs. Now, this is why my doctors won't give me a diagnosis. It seems many others are in my situation. Could you explain why and how pain is associated so that she can take things further with her doctor?
I see pain in a lot of my periodic paralysis patients, and a lot of it's because the patients also have myotonia and muscle contraction, so that really does cause them to have pain, and they have pain in almost all their muscles. The problem is, again, it's hard for physicians who don't understand the disease, that it's a channelopathy, and there's a lot of overlap between some of them, that they also have pain. So it's just a problem with concepts and understanding the disease, and it's also very rare. And then the other thing I think I discussed in my talk was that pain can be excruciating, and I have had patients say they don't want to live their life like that, and we have to work very hard to treat that pain. So it's just not only just a lack of knowledge on the physician's part, but it's also the extreme pain that's very hard for physicians to understand. And so I feel bad for this patient, but that's why we have these conferences, that's why we come together, and they just absolutely need to find a physician that will support them. And then again, write a letter. That's what I said earlier today, is have a letter that outlines how they'd like to manage that pain, and a physician who would support that.
Thank you. Let's see, Dr. Cannon, butenamide seems to be effective as a warm down, but you didn't show them against each other. Obviously, it's better not to take medication. Is that correct?
So, great question. It's understandable that any individual would want to minimize the amount of medication required to take. And if someone has intermittent episodes that might come once a month, to take something every day for an episode that once a month, the trade-off just might not be worth it. And so you've heard this morning, Dr. Jerath mentioned this, there's abortive therapy for an ongoing attack versus prophylactic therapy all the time. So we're working towards either, because there are some individuals who have, at least weekly, if not daily episodes, and would greatly benefit from prophylactic management. And we're looking at both of those. We're also working very hard on the basis for these lifestyle changes that influence susceptibility of triggering an attack, because, people like to be in control of their destiny and can use those approaches, and there's a lot of scientific basis for that. Either one of those that I showed, the warm down or the bumetanide, could work. There was a question written in about bumetanide, and if you give me just 30 seconds or so, I think I should address that. When people see this data, you might be tempted to say, why aren't I taking bumetanide right now? Why isn't my doctor prescribing it? And every time I present this and share with neuromuscular specialists, we need to be a little bit cautious. While I have no doubt about the science behind it, this is a potent diuretic that will cause potassium loss into the urine. So there's a theoretical concern that you're going to make the situation worse in the body by lowering the potassium. I will say that by preventing an attack, you're also preventing potassium from moving into the muscle compartment, which is what happens in an attack of hypo-PP. So your total body potassium isn't low, it's just in the wrong place. It's inside the muscle. And so by preventing that shift with bumetanide, even though you're losing a little bit in the urine, the trade-off might be okay. What about more practical aspects? So Doreen Fiallo in Mike Hanna's group in London, based on our animal work, actually did a placebo trial of the CMAP exercise test with bumetanide in 10 individuals. And what they found that there was not clear evidence. Now, a CMAP test is not the same as, you know, an attack of periodic paralysis necessarily. So what was curious, they tested about 10 patients. They couldn't show necessarily that recovery of the CMAP amplitude was different. For a positive control, you had to have an attack. So they were looking at recovery, not protection from an attack. That's one thing. Another curious thing is of these 10 patients, 2 of them were in a low-grade spontaneous attack. And while their CMAP didn't improve, their general strength improved. So, you know, there might be something there. And so what I'm asking patients and physicians to do is just hold off because we're continuing to study this and it needs to be done in a crossover trial controlled way, because it would be a shame for anybody to get overly exuberant and enthusiastic about this and take too much and get into trouble and thereby think this is a bad choice and we could miss an opportunity. So the other thing is that the study in London, they used a 2 milligram dose, which is a pretty hefty dose of bumetanide, and it was very clear that no hypo-PP patient had an adverse event because of that. It did not induce weakness. So I remain open-minded, but there's still work to be done for the hypo-PP.
Okay, that's interesting. Tammy has a question. She says, I need a lot of salt because she sweats so much and because she's so cold all the time. If she lowers her salt, she gets dehydrated. So she needs salt and fluids, otherwise she has an attack.
We're assuming hypo-PP, that's the more common, or?
I think so, yeah. I kind of know Tammy, so I think so, yes.
So perspiring is one of the common ways of losing salt. That and the urine and vomiting are some of the most common ones. And you can certainly become salt depleted from that matter. And if you try to rehydrate yourself with water only, you can get into trouble. Well recognized. And as people with hypo-PP know, you have to be really careful about these sport drinks because a lot of them contain a lot of sugar, which is going to get you in trouble because that's going to promote the movement of potassium into cells. So the low salt and hydration, while it does have an effect on this co-transporter, the NKCC co-transporter that I mentioned, and in the dish, we can certainly use that as an example of potential protection. That's one piece of a very complex scenario. And as much as I'm a hardcore scientist and love the data, I would never argue with patient experiences. And if somebody finds that personally replacing, in particular, sodium is beneficial for them, go with your experience. And this is the importance of self-observation and diaries. And I'll let Dr. Jerath weigh in also.
Yeah, I absolutely agree, Dr. Cannon. I am very much on board with patients doing whatever's in their best interest. And so in this situation, it seems that if she's apparently having issues, right, with sodium intake, right, and being dehydrated. But the one question I don't understand is that when she does have sodium, that she gets an attack. Is that her concern?
No, I think it's if she doesn't take the sodium, she gets an attack.
Oh, that's interesting. So there's like, Dr. I mean, that's exactly fine if it's helping her.
Okay.
We discussed that earlier in my talk. There's some things that make patients better for some. Like pregnancy, it's better for some patients. For some patient symptoms, and it doesn't improve others. So there's not really a standard rule here. And I think that the more we get feedback from patients, the more we learn about the disease.
Okay, thank you. Lois asks, I remember that in the past, insulin was used as a test for PP. Many of her episodes seem to be triggered by low blood sugar trigger, especially when she's in the hospital situations where she can't control her diet. Can you explain chemically how this becomes a trigger? We do have a lot of diabetics too.
Yeah. So I'll start, and Dr. Jerath, you can chime in as well. So the comment is absolutely accurate. Early, like in the 60s and 70s, 1960s and 70s, insulin and glucose challenge was used as a provocative test under controlled conditions in the hospital to confirm a diagnosis. Now that we have the CMAP exercise, better understanding in genetics, it would be unethical to do those. So those are no longer performed. I will say in the mice, we've done insulin and glucose challenge, and we trigger attacks of paralysis in the mice as well. But what happens is for all of us, when you take in sugars and carbohydrates, your pancreas releases insulin. This is part of the normal control of your body using that fuel and having it absorbed in the appropriate places. But part of that absorption, especially in the muscle and liver of your body, the net result of that causes a shift of potassium into muscle. So you cause a redistribution of the potassium into muscle anytime you have a glucose and insulin challenge. And if you have hypo-PP, as you've seen, that's now going to become a trigger for the depolarization and attack of weakness. So what's a normal response that your body, you've evolved to do to help you store carbohydrate and convert it to glycogen and have an energy source, gets you in trouble if you're at risk. So the things to do are not overshoot on your insulin or your glucose. If it's dietary, think about eating fats and protein before, so that you don't have such a high spike of glucose and therefore insulin. It's a very popular thing in diet, and dietitians have looked at the so-called glycemic index, which even for amount of carbohydrate and sugar in food items, there's the fraction and how fast it gets absorbed into a blood. So if you eat low glycemic index foods, that's going to be better for you. And just be mindful of an insulin dose if you have to take insulin.
Now that's a complete answer.
Okay.
Okay.
Let's see. We have a question from Michael. It's interesting. Dr. Cannon, is there a way for patients who have an unknown genetic variant to submit a sample to someone who can help determine which one they may actually have?
Yeah. So great question. And to give you a sense of this, and I've spoken to some members of the Periodic Paralysis Association on this issue, it requires, even for someone who's experienced in this area, it requires 2 or 3 months of dedicated work by one person full time to functionally test one of these mutations. And as I think Todd Bell mentioned, and it was mentioned in the Strongbridge presentation as well, there are different levels of evidence of establishing that a variant is mutation causing. So one is what I mentioned, to make the mutation in the lab and study it. That takes 3 months, low throughput, one at a time. The other is by seeing how this variant segregates in a family. So if you have a family with multiple affected individuals, and this variant co-segregates only with the affected people and not the unaffected, that's increased evidence. And what we know very clearly is that the very same mutation, there can be hotspots, might have occurred spontaneously in a completely unrelated family. And if they have the same change and inherits in a similar pattern, then you're really getting strength of evidence. So just like the diagnosis is a spectrum, the confidence of the genetic assignment of pathogenic versus benign is on a spectrum. And in our lab, I'll share with you that from stories I hear at the PPA meeting, I'm intrigued by cases where it's clearly strongly inherited in this family. And yet it's a variant that hasn't been studied yet, or there's something unusual about a trigger. And we want to understand the science of the trigger and this particular mutation. We will go out and study that. And we're doing that right now. I wish I could say we could provide a service, but it's just not feasible. There are hundreds of variants out there of unknown significance. And the last thing I'll say, and I don't mean to manipulate the answer time, but technically, it's much easier to study in the laboratory the consequence of a mutation of the sodium channel or the chloride channel than it is for the calcium channel, or even worse, the ryanodine receptor, RYR1. So it's not equally challenging to do the functional tests in the laboratory, and that's why there's a difference in the level of certainty and the rate of screening through these different mutations.
That's excellent. I just wanted to add to that because our clinic runs heavily on interpreting variants. We do a lot of genetic testing in patients and spend a lot of time testing family members and investigating whether a variant is actually disease causing. And I've been blessed to have that experience when I was in Iowa, just to learn about, whether variants should be disease causing or not. It's very tricky. Sometimes it's impressive, Dr. Kennett, it takes you a few months. For many people, it takes years. It takes them many years to find out if a variant is disease causing in an actual functional study. But what we do, and if you read some of the papers I've published, we really try to interpret the family history to see if there's any other family members that have that variant and also have the same symptoms, and then we try to publish it. So that's why if you have family members who are affected, you have other people, the more people we get who get involved, who actually do the genetic testing, the more information we'll get. And I have a lot of variants just not even for periodic paralysis, but also for hereditary neuropathies, for a lot of hereditary neuromuscular conditions. So that's why I tell patients to go out, see their doctor, to get the help, see the right physicians who are going to take this to the next level.
Okay. Miriam asks, if no myotonia is seen on an EMG, but a person has all the symptoms of myotonia and hypo-KPP RYR1, should they even mention their myotonia symptoms?
So I don't know. I can comment, or I feel I should let you go first, Dr. Jerath, if you want to talk about complaint of symptoms, but a normal EMG.
So the question is whether she's had a normal EMG, but she has myotonia. Is that the correct? And she said that she doesn't believe that the other physician thinks she has myotonia because of her EMG. Is that
there was no myotonia on the EMG.
Correct, but she clinically feels she has myotonia, right?
Right.
So that's what's really hard, and I did bring that up in some of the cases I brought up, that RYR1 in the chart, cases I talk about all over the country. It's not, our EMG testing is operator dependent. It's not 100% perfect all the time. So I do tend to focus on the clinical presentation, even if we don't happen to find a perfect fit with EMG. I would love for it to show myotonia. That would be a perfect scenario, but not every EMG test is perfect, and each individual is different. We've had patients who've had normal EMGs, and they're 30 EMGs abnormal. And then you're like, wow, now this patient has a neuropathy, or now this patient has myotonia. So sometimes it's not evident on that first EMG. And these are diagnostic difficulties. They're hard. They require a lot of patience and a lot of tenacity. So the patient should never give up. If she really feels like she's having myotonia and she needs it to be treated, she should tell her doctor.
Well, it's getting close to time to close, and I'm going to reserve the last question for the PPA, both of you. And I would personally like to know if there's something that the PPA can do as an advocacy group to further the work done in periodic paralysis. And I don't necessarily mean financially. I mean, is there anything we can do as far as bringing doctors together to talk and giving them a platform? I'm open to any ideas that you might have.
So I'll start. First of all, I appreciate everything you have done. The awareness has increased phenomenally. I mean, I started with this in 1990 when I had my first opportunity to study a muscle biopsy from a patient. And it's gone from obscurity to, now it's taught in medical school and more people know about it. So your awareness campaign is great. The fact that you provide resources for patients and physicians and the reprints and descriptions is extraordinarily helpful, because to go even as a healthcare professional and do a Medline search or something for periodic paralysis, it can be bewildering. And comes back to the clinician is a mixture of hardcore basic science papers and clinical papers, and it can just be, oh my gosh, this is overwhelming to sort through. And you have done a fantastic job at queuing all that up and making it very accessible, timely, renewing it as more information becomes available. So that's fantastic. I will just also say, and then I'll let Dr. Jerath speak, that we all are data-driven as scientists and physicians, and I understand the importance of carefully designed surveys and everything, but I can't tell you how much I appreciate coming to the PPA meeting, in particular when it's live, so that I can personally hear the stories, and even more importantly, at the end of a talk like this, I can ask a show of hands, just like we attempted to do. And while the rigor of that might not be high, the value of that feedback is incredible. And I have certainly been educated about things like the pain that comes with myotonia and what triggers an attacks. And so bringing people together, having physicians come, I think moving the meeting around to different locations in the country or even internationally. I know mobility is an issue for a lot of people, but that helps bring new people into the fold, I think, by having it be local. So those have all been helpful things.
Thank you. Dr.
Jerath? Yeah, I would agree, and I think that in some way I think we need to get the physicians who are leaders in this field together to move forward and to get information. And this would be leaders outside of the United States. I know Dr. Lehman Horn is no longer here, but I'm sure he has a lab and a legacy that we could connect with. So I think that we would want to connect with those leaders. We also want to connect with the patients. That's a big deal for me because my research is patient-driven. My patients just tell me things that I'm learning from them every single day. And so if they don't tell me, if they don't speak up, if they don't get their genetic, they don't have to get genetic support. If they don't get it, if they don't come, then we're losing out on our knowledge. So that is a really important piece. And so bringing all those patients to come see me or to see the other leaders in the field has been just phenomenal. So really grateful to the Periodic Paralysis Association for that. I think from that next step, we need to create research studies. And that's something in my mind since that initial question about how to redefine the diagnosis came up. I'm thinking, how can our patients help us with this? How do we move forward? I mean, do we do surveys? But they're not scientifically rigorous, right? So that's a huge problem. Do we have to have them come to my clinic, come to see Dr. Cannon? I mean, come together and get all the variants and everything sorted out in terms of the new presentations. So there's a little bit of work that we need to do together behind that to actually move the field forward. I think we're right there, but maybe coming together in some way. This conference was excellent, a great first step, but coming up with research ideas that we can all do as a group, it's just natural history is a good beginning, more than anything else. So that's my feedback. I'm just so blessed to be part of this and grateful for all the patients that we can help.
Well, thank both of you. You've been wonderful, and we will be seeing you again next year in person, we hope. So I'm going to take presenter back because we have come to the end of the conference, and I just have a couple more words to say. So I'll talk to both of you soon, and I'm just going to change. Bye-bye.
All right, bye. Thank you.
Okay, as soon as my screen comes back here, I just wanted to say a couple of things before we sign off. If I can get it to work. We shall see. My hourglass is going very slow right now. No. Come on, there we go. I seem to just have a slow computer all of a sudden. It's just been wonderful today, and I truly appreciate all of the attendees who have been here listening all day long, and special thanks to all of our doctors who have been with us. I would like to ask all of the attendees who are still here to keep your screen open for a few minutes when the conference ends, because you're going to have a short poll on what you thought about the conference today. Tomorrow, you're also going to be receiving an email from us with a short survey, and we would like you to return that to us, as it will provide us with information for future webinars we will be having throughout the coming year. And that's something that you should all know, is that the Periodic Paralysis Association, now that we have this format for doing webinars, we hope to be doing these on a monthly or bi-monthly basis with various individuals on different topics. It'll be a much shorter webinar, maybe an hour to an hour and a half. We hope that these short webinars will bring you news, and as we receive it, and keep you engaged as members of the PPA, because we need your input now more than ever. And that's really what Dr. Cannon and Dr. Jerath just alluded to. So thank you for attending today. It's been a whirlwind day, and a lot of work went into this. We were scared starting out, but so much information has been given to us, and I just want you all to digest it, reach out to the PPA with questions, and always, always remember that you are not alone. We'll see you soon. Bye-bye.